Good morning, everybody. This is going to be a hearing today on postpartum care, pretty much covering all the morning activity. And then this afternoon after lunch, we're going to have some presentations on obesity and then later on autism. So anyway, I appreciate the committee's indulgence in making such an early morning meeting. And Dr. Henderson, who is the pediatric with the Pediatric Clinic of Hattiesburg Clinic and at Forest General Hospital, will be our opening speaker. She's the president of the Mississippi chapter of American Academy of Pediatrics. Dr. Henderson, you have the podium. And if you would, make sure your little green light is on the microphone. Yes, ma'am. You want to turn it green?
Thank you, Chairman Blackwell, and I really appreciate the opportunity to speak today on 12-month postpartum care. As you mentioned, I'm a pediatrician at the Pediatric Clinic, which is a service of Hattiesburg Clinic. I've been there for about 25 years and serving as president for the Mississippi chapter of the American Academy of Pediatrics. So what that means is I'm representing about 300 plus pediatricians, pediatric subspecialists, medical students, and residents in our state. And just a little bit of my background before I get started. I was born in Nairobi, Kenya, and I moved to Starkville, Mississippi when I was 2, went to Mississippi State, graduated from Starkville High School first, medical school here at UMMC, traveled to Vanderbilt to do my pediatric residency, which is where I met my husband, Randy. He is a neonatologist at Forest General Hospital and at Memorial Hospital in Gulfport. So we really talk about moms and babies and prematurity in my house a lot. And that is kind of why we are here today, and I appreciate the opportunity to talk about postpartum care. Let's go ahead and get started. So first of all, let's just clear the air on what is 12-month postpartum care and how does that affect moms on Medicaid in Mississippi. Medicaid is a healthcare coverage option for low-income populations. The majority of the Medicaid recipients in Mississippi are children, and it also covers moms who are pregnant, some disabled, and a variety of other low-income populations. It covers moms generally for 60 days after delivery. During the public health emergency, however, moms on Medicaid have continued to have coverage, and that has allowed for continuity of care. So what we know is when you have a healthcare option, when you have coverage, you are more likely to go to the doctor and have those preventive services. States that have 12-month postpartum care have seen moms increase their visits for preventive care. So for care for their high blood pressure, care for their diabetes, care for all those chronic medical problems increase when they have access. And traditionally, about half of all moms in the postpartum period do not keep that 6-week postpartum visit. And that is an important visit. Moms who have gestational diabetes, and you'll hear about this from Dr. Tucker later on today, but they need to be evaluated for their chronic medical problems that may occur after pregnancy. So that is those are some of the reasons that postpartum care is so important for moms. One thing that Medicaid and 12-month postpartum care does not do is it does not provide cash to mothers. That is a fallacy, and that is a misconception that some people have out there, that Medicaid involves cash payments, and it does not. So moms on Medicaid do not get cash funding or cash payment during that 12-month postpartum period. So why are we here today talking about 12-month postpartum care? It is recommended by the American College of OBGYN, ACOG. It's recommended by the American Academy of Pediatrics, the AAP. It's recommended by the American Medical Association, American Heart Association. I really could go on and on. Every major medical organization in the United States recommends 12-month postpartum care. And every southern state has approved 12-month postpartum care or has pending action, except for Mississippi and Arkansas. And Arkansas has fully expanded Medicaid. About 65% of births in Mississippi are to moms on Medicaid. So that's 2/3 of our population. Mississippi has, unfortunately, the highest infant mortality rate in the country. It has the highest preterm birth rate. It has the highest low birth weight rate in the United States. And 1 out of every 7 babies in Mississippi are born preterm. So these are some of the reasons why we are here talking about 12-month postpartum care. This is not my idea. This is not a new idea. This is something that's recommended by every major medical organization in the United States. So this map, it's a little difficult to see, but there are navy blue states that you can see, the green states, and the light blue states are states that have expanded 12-month postpartum care, or they have pending action, or they have limited coverage. The states that are striped are states that have expanded Medicaid. And the only 2 states that have done neither of those things, neither expanded Medicaid nor 12-month postpartum care, are Mississippi and Wyoming. In fact, though, this week, Wyoming has actually passed out of their legislature Medicaid expansion in a bipartisan effort. Last year in Wyoming, the House passed Medicaid expansion and the Senate did not, but they are looking at that because just like Mississippi, Wyoming is a rural state and they are having issues with their rural hospitals as well. So they are rethinking and revisiting Medicaid expansion in that state. So in the near future, it could be that Mississippi is the only state in the country that has neither expanded Medicaid nor postpartum care. So 23 states have actually done both. The Mississippi mortality report from 2013 to 2016 reported a total of about 136 maternal deaths that occurred during pregnancy or within 1 year after pregnancy. The Mississippi pregnancy-related mortality ratio was 33 deaths per 100,000 live births. That is double the national average. The national average is about 17 deaths per 100,000 live births. So Mississippi is at double the national average. And so when you look at this graph compares the United States, Mississippi, and 10 other developed countries. You look at New Zealand, the maternal mortality rate in New Zealand is 1.7 per 100,000. In the United States, it's 17 per 100,000. And in Mississippi, we're at 33 per 100,000. So postpartum care not only improves the lives of moms, their mental health, their physical health after they've delivered a baby, that also impacts the baby that's just been delivered. So when you're talking about return on investment, you're talking about improving the life of the mom who's just delivered a baby. You're talking about improving the life of that baby because who is taking care of that baby but that mom? She needs health care. She needs access to her postpartum mental health issues, postpartum hypertension. Moms who are sick, moms who are depressed cannot care for their babies well. And that first year of life, a baby's brain doubles in size. So it's a critical time for that baby. You're also talking about providing inter-pregnancy care. That means we are caring for that mom for 1 year after delivery. We are improving spacing of deliveries, and that has the opportunity to impact future pregnancies. What we know from premature births is that if a mom delivers a baby prematurely, and if she gets pregnant again within 2 years, she is at high risk of delivering another preemie. But if she's able to wait for 2 years, the risk of delivering another premature baby goes back to baseline. So our goal is to spread out those pregnancies to increase the distance so we lower the rates of premature birth. So when you're talking about improving the life of mom, improving the life of the baby that's just delivered, impacting future pregnancies, you have the opportunity by passing 12-month postpartum care to impact 3 or more lives, which makes it a great return on investment. You've seen this graph before. This is a graph that looks at return on investment. Investing early improves outcomes. We talked about this during the child's maternal family hearings with Senator Boyd recently about the impact of early childhood development. But when we talk about return on investment, really that prenatal piece improves long-term outcomes as well because you're improving the health and the development of that child. In the United States, about 80% of pregnancy-related deaths are considered to be preventable. So we have the opportunity to reduce that maternal mortality 80% of the time. Among those pregnancy-related deaths with information on timing, about a quarter of those deaths occurred during pregnancy, a quarter occurred within the day of delivery or within 7 days after delivery, and about half occurred between 7 days and 1 year. And so when we look at the timing, a third of all those deaths occurred after that 60-day mark. So that is where we are trying to make an impact in preventing those maternal deaths between 60 days and a year. When you look at the causes of those pregnancy-related deaths, mental health conditions are the leading cause. Those deaths include suicide, overdose, poisonings, substance use disorders. When you add all that together, it is 23% of all the deaths. Hemorrhage, which is excessive bleeding, accounts for about 14% of maternal death. Cardiac coronary conditions account for 13%. Thrombotic, which is blood clots, account for about 9%. Cardiomyopathy, that accounts for 9%. And then hypertensive disorders of pregnancy account for another 7%. So when you look at all the cardiac conditions, including hypertension, cardiomyopathy, thrombosis, that is about a third of all deaths. And that is one of the reasons that the American Heart Association is so supportive of postpartum care. We really are interested in data and evidence-based interventions. This is an article from the Journal of the American Heart Association that talks about the opportunity to improve healthcare outcomes in the cardiovascular space, in the heart disease space, during that 12-month postpartum period. So women who develop hypertensive disorders of pregnancy have a 4-fold increase in long-term diagnosis of chronic hypertension at that 6 to 12-month mark. And we know that in Mississippi, we have really high rates of hypertension. We have high rates of cardiovascular disease. And so screening and patient education, lifestyle intervention during that first year postpartum is an effective prevention strategy for the development of prevention of heart disease. And in fact, I'll just tell you a story. My child, I mentioned it already, is a third-year medical student at UMC and is on his OB/GYN rotation. He actually saw a patient this week at 6 months who had postpartum hypertension. They were able to intervene with that mom and address that. She had also had a preterm birth at 28 weeks. So here we are, because of the public health emergency, we are able to address hypertension, get that mom healthy, prevent future preterm pregnancies and preterm deliveries, and impact that mom long-term. This is something I see as a pediatrician in my practice on a weekly basis, and it's postpartum depression. It is the most common psychological condition following childbirth, and it has negative impacts, obviously, on their baby's health and their cognitive development. During the public health emergency, during the COVID pandemic, we have seen increased rates of postpartum depression. We've seen increased really rates of all sorts of mental health issues. And as a pediatrician, what I do is I screen moms when they come in for their baby's checkups at 2 weeks, 2 months, 4 months, and 6 months. I, as a pediatrician, talk to their moms and screen them for postpartum depression. And prior to the public health emergency, if they screened positive at 2 months, at 4 months, and 6 months, I really had nowhere to send them. I had no options. And so that's really hard as a pediatrician to see a mom who is struggling. And you know that child is going to be struggling and I have nothing to offer them. I can send them back to their OB or their family medicine doctor, but they would be paying out of pocket, which makes it very unlikely that they are going to utilize those services. About 9% of all maternal deaths in that postpartum period are by suicide. So if we're really talking about helping moms and helping babies and helping families in Mississippi, we really need to understand the impact of postpartum depression. When we talk about addressing moms' health care, there are several aspects that we are talking about. We're talking about coverage, which is healthcare coverage and insurance, which facilitates entry into the healthcare system. We're talking about services, having a source of care, having a hospital, having a clinic. We're talking about timeliness of care. If you live 2 hours from your OBGYN or 2 hours from the hospital, having a timely source of care is going to be difficult. If your OB wait is a month or 2 months or 3 months out, having that access to care in a timely fashion is going to be problematic. And we're also talking about workforce. The Senate has really done a great job, the legislature, in terms of increasing access and workforce with the rural health physician scholars, the nursing scholarships. There are lots of programs and policies out there that are attempting to increase workforce. But all of these aspects are elements to access of healthcare: coverage, services, timeliness, and workforce. Senator Bryan right here had a hearing recently about the hospitals, and we'll talk about that in a minute, but it's really important to understand that all of these are access points. One thing we could do today, one thing we could do through the Division of Medicaid right now is presumptive eligibility from pregnant moms. Right now, it takes about 1 month for moms who have found out they're pregnant. Once they get all their information in to the Division of Medicaid, it takes about a month for them to get enrolled in Medicaid. Once they get their Medicaid card and their Medicaid number, it may take 4 to 6 weeks for them to even get an OB appointment. Some OBGYNs will see a mom prior to getting their Medicaid card, but some wait until they know that they have that access. So when you look at that time frame, some moms are far into their second trimester before they even see their OBGYN for the first time. And we know that that first trimester is a critical time where we test for infections, where we test for high blood pressure, where we get moms started on prenatal vitamins, which prevent neural tube defects. So we need those moms to get into their OBGYN as soon as possible. As of January of 2020, about 30 states have enacted presumptive eligibility for moms who are pregnant, and those states include Florida, Georgia, Tennessee, and Texas. So a number of southern states have done this, and it is something that our division could do right now to help improve access. So we've talked about our moms, we've talked about preventing maternal mortality. So let's talk about why we're doing that, and that is to prevent prematurity. So as I mentioned, my husband's a neonatologist and I'm a pediatrician. We really talk about preemie babies all the time. A full-term pregnancy is 40 weeks. Early preterm is considered 37 to 38 weeks. Late preterm is 34 to 36, moderately preterm 32 to 34. Very preterm is less than 32 weeks, and extremely preterm is less than 25 weeks. And when we're talking about these babies and how big they are, a full-term baby is about 7.5 pounds. A moderately preterm baby, a 32-weeker, which is 2 months early, maybe 3 pounds to 5 pounds. And those extremely premature babies, those babies born before 25 weeks, weigh about 1 pound. So if you can see in this picture, you can see the size of that baby. Those arms on those 24 weekers are about the size of my pinky. Those legs on those 24 weekers are about the size of my finger. So we are talking about extremely tiny, extremely fragile babies. And this is what we're trying to prevent. Why are we trying to prevent that? These are some of the complications of prematurity. These are not all of the complications. So in the acute events, it's obviously breathing problems. Their lungs are not developed. Infections, they have an immature immune system. Bleeding of the brain is intraventricular hemorrhage. Apnea, they forget to breathe. They're tiny, they don't breathe properly. Necrotizing enterocolitis is a severe gut infection, requires surgery. PDA is patent ductus arteriosus. They sometimes require heart surgery. They require eye surgery for retinopathy, prematurity, anemia, jaundice. Those are the acute problems that happen in the hospital. Long-term, these babies suffer from problems like cerebral palsy, chronic lung disease, blindness, deafness, a number of issues that affect learning, ADHD, autism, learning disabilities. Those are all complications of prematurity. They don't eat properly. Some require G-tubes, feeding tubes. And so when we look at this list of acute problems and chronic problems, you can see that we are talking about impacting the life of babies and healthcare and their education long-term. So when we talk about spending and how much might we save in our state if we were to enact 12-month postpartum care, if we were able to prevent prematurity, this is an article that was published in 2020 in the Journal of Perinatology. It looked at over 700,000 births in an insurance marketplace in Edna. The expenditures during the first 6 months of life for a full-term baby were about $6,000. And that's from birth through 6 months. And again, this is from 2008 through 2016, so those numbers are actually higher probably now. For infants born at 31 to 32 weeks, so that's 2 months early, the cost was about $124,000. So that's 20 times the cost of a full-term baby. And when you're talking about babies born before 24 weeks, that averaged about $600,000, which is 100 times the cost of a full-term baby. So some of the arguments against 12-month postpartum care are that we can't afford it. But if you look at these cost savings, if we look at preventing even a few of those 24 weekers, we would make enough money, we would save enough money in our state to pay for 12-month postpartum coverage. This is a map that was published by the March of Dimes on the United States and their premature birth rates. And unfortunately, Mississippi scored an F in preterm birth rates. We are #1 in the nation at 15%. So the states that surround us, Arkansas, Louisiana, Alabama, they're in that 12 to 13% range. So we are at an F, and Dr. Edney, who's speaking later, said, if we are last, we're last by a mile. And if we have scored an F, we are, F in a significant way. When you look at what has happened in Mississippi over the last 5 to 10 years, our preterm birth rate has increased from 12 to 13% about 5 years ago up to 15%. So we are not improving our preterm birth weight, we are worsening. And so here again is the March of Dimes report card on Mississippi. 15% of all babies born in Mississippi are born preterm. So there's been a lot of discussion about what's going to happen over the next year, over the next few years with regards to births in Mississippi. So we have a potential for an additional 5,000 more births in Mississippi. And when you're looking at a preterm birth rate of 15%, that could be an additional 750 babies born preterm. And of those 750, approximately an additional 100 will be those extremely preterm babies, those 24, 25 weekers and below. This year, 2 labor and delivery units in Mississippi have already closed. Oshner Medical Center in Hancock County and Greenwood LaFleur in the Delta. And this year, 2 NICUs, neonatal intensive care units, have closed. The NICU in Greenville at Delta Health Systems and the NICU at Merritt Central in South Jackson. So with the NICU closing in the Delta, we have no NICU between Memphis and Jackson. In our state, we really have 6 cities that have neonatal intensive care units. That would be Gulfport, Hattiesburg, Meridian, Jackson, Tupelo, and Amory. So we have large portions of the state without neonatologists, without neonatal intensive care units. And as we move forward and as we look at our #1 in the nation infant mortality rate, we need to look at how are we going to care for these babies. This is a map just illustrating those recent closures, the labor and delivery units that have closed in the Delta and on the coast, the NICUs that have closed in Jackson and in Greenville. And as you've heard recently, over half of the rural hospitals in Mississippi are in crisis, and some are having to look at things that they may limit and services that they may discontinue. We obviously hope those are not labor and delivery services, but we will have to see what happens. These hospitals are going to have to make hard choices. I just want to tell you, and Dr. Thamudi from UMMC, she's a pediatrician and neonatologist, will be talking to you more about some of her NICU moms. But this is a patient that we took care of recently, a healthy mom who delivered extremely premature twins. One did not survive due to that extreme prematurity. The other one did and spent 4+ months in the NICU. She went back to work as soon as her babies were born so she could save her maternal time, her maternity leave. And then when the baby that was surviving came home, she realized she was having anxiety. She was having some depression. She had not had the opportunity to grieve the loss of that other baby. And so here we are. Had it not been for 12-month postpartum care, had it not been for the public health emergency, she would not have the ability to get those resources, to get that therapy. And we spend a lot of money on those babies and getting them healthy and getting them out of the NICU. We really need to remember who is taking care of that baby, and that's that mom. 12-month postpartum care is not a new idea. This is a paragraph from the Medical Care Advisory Committee annual report in December of 2017. In it, the report writes that in Mississippi, many of our women of childbearing age are obese, overweight, or have chronic medical conditions such as hypertension, such as diabetes, and these conditions affect pregnancy and can lead to increased preterm births. So if these moms had access to regular health care, those moms who had previous preterm births, it would help alleviate that problem. If Medicaid coverage, which extends to 60 days, was extended to 1 year postpartum, those moms would have the ability to get healthy and to be healthier when they are next pregnant, thereby reducing preterm births. So this is not a new problem. This is something we talked about 5 years ago. And so if we're serious about helping moms and babies in Mississippi, we need to really evaluate that. If we want Mississippi to look differently in 10 or 20 years, we need to look at what we are doing now to prevent prematurity. I like Fred Rogers. He says that we live in a world in which we need to share responsibility. It's easy to say, this is not my child, this is not my community, this is not my world, this is not my problem. But these are our children. These are the children of Mississippi, and we need to do what we can to take care of them. This is not a Republican issue. It's not a Democratic issue. It's not a red state issue, a blue state issue. It's not an issue versus the right versus the left. It's an issue of right versus wrong. It is right for us to care for moms who have delivered babies. These are working moms. These are moms that I take care of. They're teachers, they're policemen, they're firefighters, they're medical students at the DO school, they're students of all type at USM. They are caring for their families, they are working, and they need our support. This is one of my favorite quotes. I like to say, children are 25% of our population, but they are 100% of our future. The future of Mississippi is being born today at Forest General Hospital in Hattiesburg. It's being born at UMC. It's being born at Octobel County, where I grew up. There's a lot of gray hair in this room. There are a lot of older people. There are a few young people. But we are not the future of Mississippi. I'm not the future of Mississippi. If we care about Mississippi and want to improve the lives of all Mississippians, we need to look at improving the lives of moms in Mississippi. So I appreciate again Senator Blackwell, Chairman Blackwell, for giving me this opportunity to talk about postpartum care. I think that the Senate has led on this issue. Lieutenant Governor Hoseman has led on this issue. In many ways, I understand that I am preaching to the choir right here, but I'm hopeful that there are other people out here in this chamber who are listening to the information, listening to the data, and looking at ways that we can improve the lives of moms and babies, the working families in Mississippi. So thank you.
Thank you, Dr. Henderson. I've got a few questions for you. And I may jump around. I apologize for that. On the preterm issue, is this the second or third delivery for these women that they run into the preterm issue? And part of that is because of the some of it lack of postpartum care, but certainly the lack of any contraception. Am I accurate there? Or?
It can be the first pregnancy. It certainly can be the second and third pregnancies. And you'll also hear some of this from Dr. Pham from UMC. But again, if you have a preterm birth, if you get pregnant again, prior to 2 years, you are at a much increased risk of another preterm birth. And Dr. Henderson, Dr. Pham can tell you they have moms in their NICUs who have had multiple preterm births. But if you space those births out, you are reducing the risk of prematurity back to baseline. So yes, 12-month postpartum care in other states has reduced preterm birth rates.
And we do have presumptive eligibility here, but it's at the hospitals. And
right.
I've had discussions with the department about, let's see how we can expand that. So, because we really don't, that's not where the women need to be going to the hospital to have or to the ER to have that determination. And so you made a comment about the importance of these women. Currently, a lot of them are not being seen until the second trimester. Can you talk a little bit about the importance of a little bit more earlier intervention, like within the first trimester?
That's right. So in the first trimester, what the OBGYNs are doing is they're looking at infections. They're looking at that mom's iron level. Do they need to be on iron? Prenatal vitamins. Folic acid is something we started doing years and years ago because we found that it prevents neural tube defects, which is spina bifida. And so moms who are taking folic acid and a prenatal vitamin during that first trimester lower their risk of spina bifida. So these are all interventions. Those ultrasounds that are done in that first trimester are very important in determining the health of those babies. If you get to that second trimester and certainly in that third trimester, you've left a large window where those moms are not receiving health care and you're increasing the odds of a poor outcome.
And then just last one, just to update some statistics. I think your numbers for maternal mortality ran through 2016. I've got some numbers from the Kaiser Foundation for 2020, and we were actually at 149.4 deaths per 100,000. The US rate was 23.8. We're more than 6 times the national average.
Yeah.
As-
Going in the wrong direction.
Yes, ma'am. Any other members have questions? Dr. Henderson? Senator Wiggins?
Dr. Henderson, thank you for your presentation. If you could put it in dollars terms, how much does it cost, medical costs to when we have a preterm birth versus a normal birth? Can you put that figure, give us that figure in general terms?
So in general, the baby's cost, the cost of the baby, a full-term baby, is about $5,000 to $6,000 in the hospital. And that includes the hospital care. Like most full-term babies stay in the hospital for 1 or 2 days. They're taken care of by the pediatrician. They have lab work done. But those premature babies, say a 23, 24 weeker, they end up in the hospital about 4, 5, 6 months, sometimes even a year. Some of those preterm babies cost well over $1 million. The average is $600,000, but many of them cost over $1 million. Some of them require heart surgery. Some of them require eye surgery. Some of them require GI surgery for that necrotizing enterocolitis. And that's just the hospital cost. So when we're talking about long-term costs, educational costs, it's much higher. So
Yeah, I'm focusing on the
mom,
I guess the hospital and the mom
Yeah.
family together.
Yeah.
So the average an average is 600,000 additional dollars.
for the baby. Now, the moms generally, it depends on what their postpartum complication would be. You know, they can deliver a baby and be out of the hospital in a day or two, but that baby stays in the hospital for 4 or 5 months.
Who currently on the preterm births, who or what pays for those preterm births, preterm costs?
Whoever that insurance is. So if it's 65% of babies in Mississippi, that's the division of Medicaid paying for that.
Say that again.
65% of babies born in Mississippi are born to moms on Medicaid. So 65% of babies in Mississippi are on Medicaid.
Okay, and 15%, by your numbers, 15% of our births in Mississippi are preterm.
Correct.
So 15% of the births are costing on an average $600,000.
No, 15% are preterm.
Preterm, right?
But of those preterm babies, about 2% are those extremely premature babies. So it all depends on how premature you are as to how long you're going to end up in the hospital. But about 2% of Mississippi births are considered extremely premature.
Which can go from 600 to $1 million.
Correct.
Okay.
So that's what if we can just prevent 1 or 2 or 3 of those births,
That's what I was
we
trying.
paid for ourselves.
Okay, that's what I was trying to get.
Right.
So if you do the coverage and you prevent them, then your exponential cost savings are there.
Exactly.
Okay.
It's estimated, and you've got Drew Schneider talking later, but I think the estimates are that 12-month postpartum care might cost about $7 million for our state share, $70 million completely, whereas, the federal government pays about 90+%. So if we are just talking about spending about $7 million, again, if we just prevent a few premature births, we will be able to pay for this coverage for all moms, for 65% of the moms in Mississippi.
Senator Blunt?
Thank you, Mr. Chairman. Thank you, Dr. Henderson. It sounds like you're a numbers guy. I thought your presentation was outstanding. I hope you can provide it to us, the slides to us. With regard to postpartum care and presumptive eligibility, and Senator Blackwell and the Lieutenant Governor have been pushing this for a while, but with regard to those two issues, isn't it true that the executive branch today could make that happen without waiting on the other chamber to join us in this effort?
Yes, to my understanding, that is correct.
This afternoon,
Correct.
he could sign a piece of paper and we could solve these problems.
Yes, sir.
Well, if that doesn't happen, I think you'll see a continued commitment from the Senate, and I thank you for coming today.
Any other members? Carlos, do we have any committee members online with questions? Thank you, Dr. Henderson. I appreciate you coming in, and want to wish you a happy birthday as well.
Thank you.
Next on the agenda, we have Dr. Edney. He's our state medical officer. He's going to be Zooming.
Yes, sir, Mr. Chairman. Can you hear me okay?
We can. Welcome.
Thank you so much, and members of the committee, and I apologize that I couldn't be with you today. I'm actually at Dr. Henderson's home facility in Hattiesburg, touring one of our healthier hospitals in the state and talking to the next generation of physicians in the family medicine program about public health and about the challenges that we have with healthcare in Mississippi, and helping them to understand their very important role as they go out into clinical practice very soon. Otherwise, I definitely would be with you, but thank you for allowing me to visit with you. And thank you for your interest in this critically important public health issue. And you just heard one of the best presentations that I have seen and heard over the last year, and very nicely lays out for you the problems that we're dealing with, the unique challenges that women in Mississippi face, and the importance of looking at this issue with postpartum Medicaid extension. And I use the term extension because, unfortunately, this topic has gotten muddled up with the entirely different conversation of Medicaid expansion. And what we are talking about, as I think you will know, we're talking about maintaining current benefits for women who are already enrolled in Medicaid. We're not talking about enrolling a higher number of women into Medicaid, but to have the option that's before us now to continue the present services we're providing through 12 months rather than just 60 days. I think you know that this emergency benefit as part of the rescue plan with the federal pandemic emergency response, unless we do something, will go away upon expiration of the emergency order. And that could be any time. We've been told that we'll be given a 60 days heads up when the state of emergency will be lifted. We've not been notified, so we have at least 60 more days in the current situation. But very likely by next spring, we will not be under state of emergency. And unless we act as a state, our Medicaid moms will go back to only 60 days of postpartum coverage. What I want to do for you is to talk from a public health standpoint why this is so important. So you already know, you've heard from me and many others. You just heard from Dr. Henderson that Mississippi continues to struggle with our both maternal and infant morbidity and mortality. The mortality gets a lot of attention, but Dr. Henderson just outlined a lot of morbidity, meaning illness. And we invest a lot of resources trying to help these moms and babies survive pregnancy and preterm birth, low birth weight situations. And if they survive, they still have paid a heavy cost. And of course, we want them to survive. You know, you quoted our extremely high rate compared to the nation with our maternal death rate. And with the wisdom of the legislature, the Maternal Mortality Review Committee was established and was placed under the Health Department for its administration. But you know, it's an independent body that reviews every maternal death. Any woman who dies in pregnancy or who dies within a year of delivering, those deaths are reviewed. Families are interviewed. This committee spends a lot of time and energy, and our employees at the agency spend a lot of time and energy getting as much information as we can so we can determine whether this death was pregnancy associated or pregnancy related. The pregnancy related are the more serious deaths that relate specifically to the pregnancy, meaning had she not been pregnant, she would not have died. So she has died from a direct result of her pregnancy. And that continues on into the postpartum period. Actually, the majority of our deaths do occur in the postpartum period. And based on the MMRC data that's reported to me, that about 34% of the deaths occur after 6 weeks. So getting very close to that 60-day period. And it's not uncommon for women to die in the 6-month postpartum, especially from mental health complications, postpartum depression, substance abuse that was treated in pregnancy while they were on Medicaid. If they lose Medicaid, they lose access to treatment for their substance abuse issues and become part of the opioid statistics, being an overdose death, and which is another important issue for the health department. But, it's important to understand that African-American women in pregnancy die at 3 times the national rate, and that Caucasian women in Mississippi die at 1.9 rate. Now, you quoted the most recent data, Chairman Blackwell. What Dr. Henderson was quoting was our last MMRC report data. We are about to issue our next report very soon, but unfortunately, COVID caused a significant amount of excess death among pregnant women, and it's going to take some time to tease that out to try to get to what the baseline would have been without COVID. But I can tell you now, in the post-COVID, post-pandemic world, the death rate is looking about the same. So I'm not seeing any improvement. And the 3 numbers I look at every month are how many maternal deaths did we have, how many infant deaths did we have, and how many opioid deaths did we have. And those are 3 statistics very important to me. Y'all know better than anybody that Mississippi is impacted by poverty at the highest rate, or close to the highest rate, or the highest rate of other states in the nation. And I can tell you as a public health issue that poverty equals health disparities. And a lot of what we're talking about with Mississippi having excess maternal death and infant death is not related to poor medical care. We have experts like Dr. Henderson and her husband all over the state. We have outstanding OBGYNs and their teams doing excellent care, providing excellent care for our women and children. But we have increasingly difficult problems with access to care. And we are scored very low on the national average based on our population's ability to access care. And we very recently had the Public Health Committee meeting about the hospital crisis. And as y'all know, access to care in the Delta especially is becoming increasingly difficult. and it's going to make all of these issues amplified. So I have no doubt that over the next 3 years, that our numbers are going to get worse. If we do nothing, they're going to get worse. I think if we do everything we can, they will get worse, but not as exaggerated as what I fear. The two things that worry me the most are the hospital crisis we're looking at, reduction of services, and closure of hospitals. And I'm also concerned with increased number of births that we'll be looking at. Normally, Mississippi has 37 to 38,000 live births per year. Conservatively, I shared with y'all, we're looking at around 5,000 more births. So we're going to be well north of 40,000 plus, probably closer to 45,000 live births going forward. And watching the reduction in pharmacologically induced pregnancy terminations, it looks like that's about to be right, that we're running over 1,000 less terminations per quarter. So we're going to be between 4, 5, maybe 6,000 more live births. And that's a good thing. But we need to invest what we need to do to make sure those live births are as healthy as possible, and that those live births have healthy mothers. And as we do what we need to do, and we have women surviving their pregnancy and surviving their postpartum period, and their babies are surviving their first year of life, we will have a healthier Mississippi, and we will start working our way off the bottom. One reason we're at the bottom is because of what we're talking about today. As long as we are number one in the nation with these issues, we're going to continue to be at the bottom. As long as we have, 13% uninsured rate in the state with difficulty with access to care, we're going to remain at the bottom. As long as we have rampantly uncontrolled diabetes and its complications and escalating opioid death rate, we're going to remain at the bottom. But there are solutions, and you're looking at one today. So please divorce the Medicaid expansion debate from postpartum extension of benefit. We can have another discussion about Medicaid expansion at another time, but it's critically important that these mothers who are currently receiving care for 12 months not lose that present benefit, so that we don't have excess morbidity mortality that is unnecessary for these women in the postpartum period. The data given to me is that out of the deaths we're looking at, 80% are preventable. So the MMRC group looks not only at whether it's pregnancy related or pregnancy associated deaths, but they also look to see if it was preventable or not. And then they make recommendations to us and to you regarding what we need to do as a healthcare system, as a state governance, to provide better care to prevent these deaths. And I hope that as the agency releases the committee's report to you, that you will thoughtfully look at those recommendations. They have been before you before, and many of them have not acted on yet. The World Hospital crisis is a real deal, and it's clearly going to get in the way of receiving access to care. And as you hear Dr. Henderson, you're going to hear others testify today, the later that women present in the prenatal period for care, the higher her death rate is. So we must access these women and help them receive care as soon as possible. And the health department is going to be working hard to improve that through the Healthy Moms, Healthy Babies program. Dr. Henderson said 65% of the babies are Medicaid babies. So this is very much a Medicaid issue. And Mr. Snyder will be testifying before you and will have good information for you on that. But that statistic is just to reinforce how important this topic is, and that we maintain postpartum coverage for these women as we're doing today. I want to share with you something that's quite drastic. If you look at all the southeastern states, Mississippi is the only southeastern state that either has not adopted 12 months postpartum. Texas, it has done 6 months, but they're coming into the SEC, but the rest of the South states have either adopted 12 months postpartum or they have adopted Medicaid expansion. We're the only southeastern state that has done neither one. And we're only 2 states in the nation that have adopted neither. So it's only us and Wyoming that have not adopted 12-month postpartum and also have not adopted Medicaid expansion. So I just want to show you they were kind of isolated in our current policy. Certainly, there's no doubt in my mind as your state health officer that should we eliminate this benefit, things will be worse than it would be otherwise. I'm commonly asked, well, what did the data look before we had 12 months? Well, you have to understand the 12 months benefit came about because of public health crisis, the pandemic, and we have seen significant excess mortality related to the pandemic with our pregnant women. So I don't have apples and apples yet. But if we continue to expand 12 months postpartum, we will be able to present you that data. But intuitively, it just makes good medical sense that the longer that a woman has access to care in the danger period, the better her chances are of survival. I want to let you know that the Mississippi State Department of Health is preparing for this. I have to assume that by next spring, we won't have 12 months postpartum. We are already, even if we do expand 12 months postpartum, we'll have areas of the Delta that are virtual healthcare deserts. And so we are already putting together partnerships to try to plug holes around the state that we are seeing develop. And we are talking with UMC, we're talking with NQHC around the state to look at what we need to do to expand perinatal care irrespective of Medicaid. There are women with Medicaid that still struggle with access to care. So we are utilizing our county health departments in key areas, not everywhere, but especially in the Mississippi Delta, to improve access to care for our pregnant women and make sure that they get access early, that they're seen often, and that they receive the care they need. And we'll be doing that in cooperation with our other public and private partners. I wish we didn't have to do this. I don't have the resources to do it, but I will have to shift resources from other areas within the agency to make sure these moms are cared for. What I would beg you is to consider the fact it makes much more economic sense to let Medicaid pay for this care instead of the state paying for it, either through having to fund the health department to do it, or hospitals having to take care of it through uncompensated care, which means we all pay for it. The cost will be there regardless. It just makes good sense to me from a public health standpoint to keep doing what we're doing now and try to work to expand access to care and not restrict it further. Prevention is critically important. Senator Blackwell, you alluded to this. I want to reinforce that point. If we have women who are still receiving benefits through 12 months, those are more opportunities of engagement for education. The number one thing they need to learn is with their next pregnancy, how to reduce the risk of death. And there are simple things we can do. Number one, inter-pregnancy spacing. And so it gives us an opportunity to work during that year with their family planning issues, make sure they have access to contraceptive care, educate them that diabetes, hypertension increases your risk of death, high BMI levels increase your risk of death. All the things that we know will increase a woman's risk of death, that we're able to teach our Medicaid moms while they're with us in those 12 months postpartum. Prevention is the least costly form of medical care and pays the highest dividend. And again, just to reinforce for y'all that, we need to be prepared that based on multiplicity of things that we're looking at, that our death rate likely is going to look worse the next couple of years. I think it's just critically important that we are doing everything within our power to keep that number as low as we can. And I think, we have a duty to do so, and I just want to reassure you that the Department of Health will do everything that we can to help keep that number down. So, Senator, without that, to answer any questions.
Thank you, Dr. Edney. As it relates to the mortality, maternal mortality, I mentioned the Kaiser Foundation. I had some numbers from 2020, and they were surprisingly high. I mean, we're 6 times the national average. I was just wondering how many of those deaths were attributable to COVID? And then along with that, would you happen to have any 2021 numbers on maternal mortality?
We're still looking with the complications of COVID, and it's going to take a bit for us to statistically tease out the COVID deaths. Many of the COVID deaths would not have died otherwise had they not had COVID. Some of those would have because they were high-risk moms and in many ways otherwise. I hesitate to put numbers out that I've not able to statistically validate. But looking at my month numbers, the last half of 21 and last half of 22, we're back to that more like 33 per 100,000 death rate that we had pre-COVID. I'm afraid that if we don't do everything that we can, that death rate will go back up to what you saw with the Kaiser numbers. So there's no doubt the Kaiser numbers they're not inflated, but they're elevated due to COVID. Those numbers are coming down significantly, as we're not just seeing the number of COVID deaths in pregnancy that we were before. And we are just now moving into the COVID-related deaths with the MRC work. I will get, as soon as I have numbers, I'll get to you.
All right, thank you, sir. Do other members of the committee have questions for Dr. Edney? Senator Blunt.
Thank you, Mr. Chairman. Dr. Edney, I asked this question of Dr. Henderson earlier, and I just want to confirm, isn't it true that the executive branch today can extend presumptive eligibility to pregnant women in Mississippi for health care, and today extend postpartum coverage for new mothers?
Yes, sir. I know for certain that the extension of benefits in the postpartum period can be requested from CMS by the executive branch or the legislative branch by statute through an 1115 waiver or through amending the state health plan. The easiest way is to request an 1115 waiver that CMS is granting everyone. No one's been denied, and different states are doing it differently. Texas goes 6 months instead of 12. I mean, you can look at, if you're needing compromised positions that still achieve what we need to, we can look at covering high-risk moms through 12 months. We can leave it to the discretion of physicians based on complicating social determinants of health that put women at risk. But I think Dr. Henderson laid it out very well that we're talking about probably a budget positive issue. If we're doing what we need to do, we're going to save Medicaid money by reducing low birth weight and the excessive cost that we're having to pay for those. Senator Blunt, if we don't do something, then the number of low birth weight babies will go up. This 5,000 plus new births are not going to be, they oftentimes will be high risk. They're unplanned, they're unwanted by definition, which tends to put them in a higher risk category. And so that's my concern, is that we just cannot look at an escalation in the number of low birth weight babies compared to where we are today.
Well, and I know you know the bipartisan commitment of the Senate on this issue, but I'm saying that today we can do this as a state. Today, all we have to do is ask for it.
That is correct.
Thank you.
And when you look at what other states have done, it's probably about half and half. Half the executive branch has requested, half there's been legislation passed to require it.
Any other questions? Oh, do we have any committee members online with questions? And Dr. Edney, just so you know, Medicaid's going to be presenting later today, and they're going to have some presentations on some cost estimates. And given the state share of almost $1 billion, the cost is almost negligible. And I think back of the old, I think it might have been a Midas commercial, you know, where they were talking about, you can pay me now or you can pay me later.
That's it.
The cost later is obviously significantly more. So the relatively minimal amount that it would cost the state to provide this care and the savings on the back end it's a no-brainer from my position.
And it is from mine as well, Mr. Chairman. And as I said, we're going to have to spend the money one way or the other. I would rather give money to Mr. Snyder instead of giving it to me.
Any other questions or anything? Dr. Edney, thank you for taking the time to be with us today.
My pleasure. Thank you.
We're about 15 minutes earlier. I don't know if Dr. Tucker is here. Dr. Tucker, and how about Dr. Famadi? All right. Are you prepared to go ahead and start? So next up, we have Dr. Tucker. He's the chairman, Department of OB/GYN at UMMC.
Senator Blackwell and members of the committee, thank you very much for this opportunity to speak with you this morning. It's certainly a privilege to be invited here and a privilege to be here this morning. I do want to take a lead from Dr. Henderson and tell you a little bit about myself, because I think it will illustrate, you know, why I'm here and why I feel so passionate about these issues this morning. Although I was not born in Mississippi, I was born in Washington, D.C. My dad had the good judgment to bring his young family back to Mississippi when I was 18 months old. And I grew up in Aberdeen, went to public school there, Ole Miss for undergraduate school, medical school and residency here at UMC. And except for a 2-year fellowship at UAB in Birmingham, my family and I have spent the last 40 plus years in the Jackson area. My wife is a nurse before she became a mom. She too is a UMMC graduate. We have 4 daughters. The oldest is an OB/GYN who's doing some postgraduate work at Vanderbilt. My second daughter is also a graduate of UMMC, is an internist. She and her husband, who's also a graduate of UMMC, are in Albuquerque, New Mexico, doing some postgraduate training. He's an orthopedic surgeon. My third daughter is a nurse. My fourth daughter went off track a little bit and became an accountant, but she's married to a UMMC graduate who is a family practice resident in the Fort Worth area. So we are, as a family, invested in healthcare. We are invested in this community, and we are invested in Mississippi, and that's where my passions lie. I was asked to talk about maternal and fetal physiology this morning. And when I first got that invitation, I thought, you know, that's kind of a strange ask, you know, for a forum like this. And, you know, if you're a physiologist, physiology is what you live every day. It's interesting. It's what you do. If you're a doctor, we learn a lot about physiology, but we don't really think about it day to day. We take care of patients, and really physiology is kind of down in the weeds. If you're somebody else in the community, physiology can be quite boring. So in the next 20 minutes, I'm going to try, first of all, not to bore you, and I'm going to try to hit top of the waves as far as physiology of pregnancy is concerned. And as I go through this, I want you to look at this, and the analogy I make is that the physiology of pregnancy is like a 9-month stress test on a woman's body. And as I go through the building blocks, and we'll go through about 8 or 9 systems as we go through this, and as we go through each system, I want you to think as we go from one system to the next, how that escalates and how that building block, puts stress on a woman's body. And then we'll finish up a little bit talking about, very briefly summarize why this physiology is important, and then talk a little bit about preconception and interconception care. So we're going to start with the cardiovascular system first. Cardiovascular system, as you know, involves the heart and the peripheral vascular system. There are anatomic changes that take place during pregnancy. The heart usually is kind of the left side of the chest. It's kind of displaced upward and outward as the pregnancy progresses, as that uterus and baby grows during the pregnancy. The muscle mass of the heart actually increases during the pregnancy. The left side of the heart, the atrium and the ventricle, both increase in size and become enlarged. If we look at a chest x-ray, and I don't have a pointer here, but on the left, you can see the non-pregnant chest x-ray and the heart kind of in the middle there, that kind of darker area. On the right side, you can see that heart is much larger as compared to the non-pregnant state. The blood volume expands. Our blood volume is about 5 quarts, 5 liters in a non-pregnant state. That volume increases by up to 40%. In addition to that, the red cell mass also increases. And these are very important parts of the physiology of the cardiovascular system, because that blood volume and red cell mass is important for the development of the baby. Functional changes include increased blood flow to the uterus and placenta. About 20% of the cardiac output at term goes to the uterus. This is about 1,000 cc's a minute. About a quart a minute of blood volume goes through a pregnant uterus at term. Cardiac output is a function of stroke volume and heart rate. This increases by about 30 to 50% during pregnancy. So in a normal non-pregnant state, our heart's working very hard every day to allow us to live, allow us to do the things that we do every day. And just think about that. During pregnancy, that heart has to increase by a function of about 50% over the course of the pregnancy. Cardiac output is a product of both stroke volume, the amount that heart actually pumps with each contraction, and also heart rate. So the stroke volume increases, the heart has to increase or pump more blood, and it has to do it at a much higher rate as compared to the non-pregnant state. Blood pressure actually decreases in early pregnancy, and this greatest decrease is seen about halfway to 2/3 of the way during pregnancy. And then over time, as we get back to, or as we get to the end of pregnancy, that blood pressure will go back to normal levels. Common pregnancy symptoms related to the cardiovascular physiology changes during pregnancy include dizziness, lightheadedness, syncope, or actually passing out. Pregnant women have trouble lying on their backs during pregnancy. You can lie somebody on their back, they'll get a little short of breath. We kind of move them to side, but these are all common symptoms that we see related to the physiologic changes related to the cardiovascular system. So not only do we have these changes that occur during pregnancy, but then labor comes. And so we've got this baseline where we're at as far as normal, and that we increase that by 30 to 50%. Now we're going to go into labor, and that cardiac output increases by 1/3 again. And during the second stage of labor, when somebody's pushing, it increases by an additional 50%. So fortunately, young people have babies who have strong hearts, who have strong kidneys, who have strong lungs, and they can tolerate this, especially on the relatively short term. But like I said, we start with those stresses on the heart as the basic building block for this physiology as we go to other systems. So the respiratory system, our lungs. So the goal of the respiratory system is to meet the goal of increased oxygen demand for the mother and fetus. Obviously, the fetus, the baby, is supplied by the mother during pregnancy, the oxygen, the nutrients and the like, and the respiratory system has to work overtime. Pregnancy requires about a 20% increase in oxygen consumption during pregnancy, and 50% of this increase is consumed by the gravid or pregnant uterus and the baby. Anatomic changes, much like the heart that we talked about, the diaphragm is elevated by about 2 inches. The chest diameter increases, the distance around the chest increases, all changes that you would intuitively expect as the pregnancy progresses. We see changes in acid-base balance during pregnancy. If you go to a waiting room and watch all the pregnant moms sitting around, they're all breathing real fast. They breathe real fast because of the physiologic changes during pregnancy, this relative what we call respiratory alkalosis, where their pH is a little bit higher, and those changes are necessary to keep one's pH within normal range. Respiratory symptoms during pregnancy include dyspnea or shortness of breath. Pregnant women are oftentimes prone to sinusitis and rhinitis, sinus type troubles. As I said, as far as the acidosis or alkalosis is concerned, if you do certain type of diagnostic testing, you will see some changes in respiratory changes throughout pregnancy. Back to our chest x-ray, we looked at the heart earlier, but I'll call your attention this time to the lung fields. That, as you can see there on the left, in the non-pregnant state, we see a fairly clear lung field. In the pregnant state, especially in the advanced pregnant state, we see this increased vasculature in the lung fields that you see there surrounding the heart. Once again, some of the anatomic and physiologic changes related to the respiratory system. Third area is the hematologic system, our blood and our blood flow. Once again, much like the respiratory system, what we're trying to do is maximize oxygen carrying capacity of the mother to deliver adequate oxygen levels to the fetus. This increase in blood volume and increase in red cell mass during pregnancy allows for this to happen. As we talked about earlier, the blood volume increases by up to 40%, and the increase in plasma volume, the liquid part of the blood, also increases by up to 50%. Dr. Henderson mentioned this earlier about how pregnant women are prone to anemia during pregnancy, and indeed the requirements for iron go up precipitously during pregnancy, and it requires a total of 60 milligrams of elemental iron as the pregnancy progresses. Other changes, we see an increase in the white blood cell count, the infection fighting cells, our platelets, which are the component of our blood which allows us to clot when we get an injury. Platelets may actually decrease during pregnancy, and then coagulation factors, which also are important for clotting when we get an injury or a cut or whatever. Those coagulation factors actually increase. And this is a very important aspect of physiology of pregnancy, because that increase puts pregnant women at an increased risk of thromboembolic disease, blood clots in their legs, lungs, and in worst case scenario, these types of things can be life-threatening. Common symptoms include edema or swelling, especially in women who are anemic. And we talked a little bit about the anemia earlier, talked a little bit about the increased risk in white blood cells. We go there from the hematologic system to our renal system, to our kidneys. The goal of the renal system is to maintain fluid and electrolyte and acid-base balance. Much like the changes in the heart, the size of the kidneys increases. The renal volume, or actually, not only the length of the kidney, but actually the size of the kidney increases. And we see an interesting aspect within the actual internal area of the kidney, the so-called collecting system of the kidneys will dilate during pregnancy. And the importance of this is that it puts pregnant women at an increased risk for urinary tract infections and severe infections, which are called pyelonephritis. Anatomic changes, like I said, enlargement and dilation is usually right-sided, more so than left-sided, and this is due to the orientation of the growing gravid or pregnant uterus in the mom. Functional changes include a increase in renal plasma volume. This blood flow through the kidneys increases by up to 50%. You'll see that recurring 40 to 50% in just about every one of these systems that we mentioned. It's common to excrete a little bit of glucose in the urine during pregnancy, and it's not uncommon to lose a little protein or other building blocks of proteins during the pregnancy. Common symptoms include urinary frequency, bladder prolapse, and as I said, proteinuria and glucose in the urine is also very common. From there, we go to the gastrointestinal system. The gastrointestinal system basically starts at the mouth and ends at the lower end of the gastrointestinal system. Alterations during pregnancy include both hormonal changes and mechanical changes. As we've mentioned earlier in the other systems, we get displacement of the intestines and stomach upward. The esophageal sphincter doesn't work as well, puts these women at increased risk of heartburn and other upper GI changes. Most of the hormonally mediated changes during pregnancy are due to a hormone called progesterone that's made in very large amounts in the placenta. With this hormonal mediation, we get an increased transit time, which once again makes women at increased risk of heartburn, constipation, and the like that occur throughout pregnancy. And you see the common symptoms listed here. Nausea and vomiting, obviously more common during early pregnancy, but also GERD or heartburn, constipation, dietary cravings, and a condition called tylism, where there's increased saliva formation during pregnancy. Physical examination, we oftentimes will see, bleeding gums during pregnancy, other problems at the lower end of the GI tract, and then even with diagnostic testing, we'll see some transient increase in liver enzymes, cholesterol levels, albumin levels, and the like during pregnancy. And once again, just to talk a little bit about decreased motility, increased gastric emptying, decreased tone of the esophageal sphincter, decreased colonic motility, and increased transit time. From there, we go to the endocrine system. Think of the endocrine system as kind of like the software of the computer. We have multiple endocrine glands throughout our body, and these glands send hormones or messages to other organs in our body to control the physiologic adaptations of these organs. And all of these endocrine organs, all of these endocrine systems are affected by the pregnancy. Probably the most important effect, and once again, Dr. Henderson mentioned this earlier today, is the so-called diabetogenic effect of pregnancy. Pregnancy is a condition which makes a person at very high risk of developing diabetes. If it develops during pregnancy, we call it gestational diabetes. Some women go into pregnancy with a predisposition to diabetes, so-called pre-diabetes. And these women sometimes will manifest their first symptoms of diabetes during the pregnancy. But of all the things in the endocrine system, I think this diabetogenic effect is probably the most important thing. Protein metabolism is certainly affected, as we talked about earlier, in the renal system. Protein, as you would intuitively guess, is an important building block, not only for the mother during pregnancy, but also for her baby, for the development of the uterus, for the development of the breast, for maintaining hemoglobin levels and the like. Lipid metabolism, lipids are also an important building block. When we think of lipids at my age, we think of bad things, high cholesterol and the like. Lipids are actually a good thing, an important thing, a necessary thing during pregnancy as part of this building block for the pregnancy and for the baby. Pregnancy is also a hyperestrogenic state. Estriol is the main estrogen that's made during pregnancy. As we talked about earlier, the progesterone levels increased. The pituitary gland, which lives in our brain, which controls so many of our functions in our body, actually increases in size during pregnancy, as does the thyroid gland that mediates much of our hormonal function in a normal state, but particularly during pregnancy. If we go from there to the musculoskeletal system, if you've been around a pregnant patient or a pregnant relative or whatever, there are lots of musculoskeletal complaints during pregnancy, from low back pain to pelvic pain to loss of bone density. Sometimes pregnant women will have an unsteady gait. If they have hernias, those will worsen during pregnancy. Sometimes the muscle wall of the uterus will separate. And all of these things are due to the physiologic changes of pregnancy, both hormonal and the mechanical effects of the growing baby in uterus as the pregnancy progresses. Skin, lots of changes there. Once again, mostly hormonally mediated, mostly mediated by a combination of estrogen and progesterone. We oftentimes see, especially in light-skinned individuals, the linea nigra, that black line that occurs. Many pregnant ladies will get the so-called mask of pregnancy or cloasma. Skin nevi, moles, and the like can enlarge and darken during pregnancy. There's increased sweating, vascular angiomas will increase. Pregnant women will also oftentimes complain of sweating or redness of their palms, so-called stretch marks. Although hair growth is normal during pregnancy, sometimes in some women, and especially during the postpartum period, they can complain of hair loss. Reproductive organs obviously change. The uterus grows to about 1,100 grams or almost 3 pounds during pregnancy. Most of this is due to the hypertrophy of the muscle cells in the uterus. And obviously breast size increases from about 8 weeks on due to increased blood flow and the hormonal changes that we talked about earlier. Ophthalmologic system. Even the eyes are affected. Corneal thickness increases through pregnancy, and a manifestation of this will be that the pregnant patient will complain of blurred vision. Oftentimes, patients will come in mid to late pregnancy, say my vision's a little blurry, need to go have my contact prescription or my glasses prescription changed. We ask them not to do that because usually when the pregnancy is over, this corneal thickness will return to normal and they'll go back to their baseline as far as their visual correction is concerned. Lastly, of pregnancy is mediated by placental hormones. Many hormones do pass across the placenta. IgG and other antibodies are transferred across the placenta, which allows for passive immunity for the fetus. And then the fetal immune system itself begins to develop at about 6 weeks of pregnancy. So one would think that all of these things go away, once the pregnancy is over, but that's anything but true. There are hemodynamic changes that occur in the postpartum period. The immediate postpartum period is associated with an 80% increase in cardiac output. Cardiac output usually returns to pre-labor values about 1 hour after delivery. But heart rate, for instance, may not normalize for 10 days after delivery. The left atrial and ventricular dimensions that we talked about earlier that enlarge during pregnancy sometimes take up to 6 months to return. And then the stroke volume, the cardiac output, the systemic vascular resistance decrease for 24 weeks up to a year. So all the policy things that we talked about earlier about, things that occur during postpartum, Dr. Edney talked about, many of the maternal deaths that we see occur postpartum. And some of these can be linked directly back to the physiology of pregnancy, which does not return to normal in some women to up to a year after the birth of their child. Just a word about fetal physiology, and as you would once again intuitively guess, most of the fetal physiology has to do with the function of the placenta. The placenta functions during pregnancy for respiration, taking the needed oxygen to the baby, for metabolite exchange, for nutrition, for hormonal synthesis and regulation. Placenta produces many hormones, including the ones you see listed there. We talked about estrogen, progesterone, but also human chorionic gonadotropin, human placental lactogen are also produced in very high amounts during pregnancy. Word about fetal circulation, just to say that fetal circulation is different than the circulation that we have as adults. It is vital to the development of the fetus. It obviously transitions very quickly at the moment a child is born. I won't go through all the steps that are listed for you there, but just to suffice it to say that umbilical blood flow is important, fetal circulation is important, it is different, and is obviously very tied and related to fetal growth. All right, so why does all this matter? Like I said, it is a stress test. And if you think of all these stresses that occur during pregnancy, and before I go through these, why does it matter? I do want to, as a matter of disclosure, say that fortunately, young people are healthy and young people get through this stress without any long-term effects. Most pregnancies are low risk, but patients often ask, is my pregnancy high risk? And the answer to that is often no, it's not high risk, but every pregnancy is at risk. And it's at risk for these things. It's at risk for heart failure. It's at risk for heart attacks. It's at risk for arrhythmias and hypertensive disorders. It's at risk for pulmonary edema or backup of fluid in the lungs, pulmonary infections. It's at risk for anemia. Pregnant women are at risk for blood transfusions. Pregnant women who have inherited anemias, these inherited anemias such as sickle cell disease are made worse during pregnancy. Thromboembolic disease we talked about earlier, where blood clots form in the legs or the lungs, can be life-threatening conditions, as can clotting disorders on the other end of the spectrum where the blood does not clot appropriately. From a renal standpoint, women are at risk of infection, kidney stones, and renal failure. From a GI standpoint, for liver dysfailure and the liver not working appropriately. Gallbladder disease is more common during pregnancy. And then from endocrine systems, we talked about the number one risk is the development of diabetes. And of course, thyroid disease can also occur during pregnancy. So all women, whether low risk or high risk, are at risk of all these things related to the physiology of pregnancy. Then you take a patient who has an underlying medical disease already and compound these building blocks on top of that, she is high risk and is at risk at a very, very much higher level for any of these happening during pregnancy. So I want to end by talking a little bit about preconception, or I guess in the postpartum period, interconception care. Preconception obviously means before pregnancy. And our goal with preconception care is to optimize health and knowledge before pregnancy. Many times, the cards are already dealt you when someone comes in and, they're early pregnant and have a list of issues that one has to address. The first thought that goes through one's mind is, gee, I wish we'd had this discussion a month ago or 6 months ago or a year ago, because, we may have been able to optimize health and knowledge before pregnancy, before we got to this point. But if you look at this, and this does not really project very well, and I do apologize, but, it starts with a good history, a past medical history, a past surgical history. Family history is important. We need to review medications, social determinants, nutritional status, immunization status, and obviously end with a good physical examination. And this circular motion of preconception care is so very important in every interaction with a woman of reproductive age who is contemplating pregnancy in the future. Because as Dr. Edney pointed out, prevention is a lot cheaper than treatment and is a lot easier than treatment. And if we can intervene at any of these points in this cycle, it's a benefit not only for that mom and her baby, but it's a benefit for all of us as we go forward. I apologize. This is real quick. So, just some basic recommendations that are very easy that we really talk about when we talk to a family who's talking about wanting to start a family. We want to optimize nutrition, and if metabolic disease is present, whether that be diabetes or other diseases, we want to optimize those diseases. Obesity is endemic; it's epidemic in our society, and optimizing weight if a patient is obese is a goal. We want to transition that patient to medications that are safe during pregnancy. As I said, oftentimes that patient will come in early pregnant and be on a medication that may not be so safe during pregnancy. Ideally, those changes should be made before she becomes pregnant. Dr. Henderson mentioned folic acid in her comments earlier and how important that is to prevent the occurrence of neural tube defects or spina bifida. We ask patients to avoid pregnancy within a month of any live attenuated vaccines. And then obviously, once again, stating the obvious to stop any toxic habits such as tobacco, alcohol, or illicit drugs. So I want to close by citing some of my colleagues. Anytime we put together a presentation, it's nice to have resources that we can call upon. And I want to thank Dr. Courtney Mitchell, who's one of our MFM faculties at UMC, her maternal fetal medicine fellows, Dr. Mustafa, Dr. Solis, and Dr. Vale, for their very kind offers to help me put together this presentation. And then lastly, I want to thank you all once again for allowing me to talk on this very boring subject this morning, and I'll be happy to take any questions.
Mr. Chairman, I clearly owe my wife a couple extra Christmas presents this year. Clearly.
Dr. Tucker, thank you. You did excuse me. You did exactly. Excuse me. You did exactly what I would hope you would do. I didn't think it was boring at all. It was very informative. And as Senator Wiggins, I'm sure that one of the reasons I wanted this presented is I've got a smidge of a healthcare background, so I'm a little familiar with what goes on. But there have been a number of comments made that pretty much after 60 days, when the postpartum period ends, these women ought to be back to work, back to school. It's like it's like they had minor surgery, had maybe a lipoma removed, and they're good to go. They're not good to go. Pregnancy has a profound impact on these women's bodies. And following up with a second pregnancy, I was just wondering if you could make a comment of that. Following up within maybe 4 months after delivery, being pregnant again, could you just speak a little bit about that impact that it had?
Yeah. So basically the things that I talked about this morning, you can put a multiplier or maybe even an exponent on those things. And from a obstetrical standpoint, in an ideal world, we recommend that people avoid pregnancy for a year after the birth of a child. There's some people who want to push the envelope, and we say, at a minimum of 6 months, but ideally is for a year. And the rationale for that is exactly as you alluded to. These things don't go away. So if they haven't had a chance to resolve, especially if there's a complication during the pregnancy, then you're starting at a higher or more difficult level already. And so that's the rationale for spacing of pregnancies for the health of the mom, for the health of babies. Dr. Henderson talked a little bit about the increased risk of a recurrent preterm birth, for instance. So there are many factors there. They're important as far as spacing of the pregnancy is concerned.
And I know you mentioned, most women are young and their bodies can withstand this. But the population that we're treating is not always that healthy. We have issues of obesity, hypertension, diabetes. And I know you did mention with those factors in pregnancy, it does add to those additional complications post-delivery.
That's exactly right. And the other thing I didn't mention age. We are also taking care of an older population of women who, for whatever reason, choose to have families, later in life. And we do understand as a mom gets older, her risk of these things also go up. Many women are undergoing assisted reproductive techniques and all later in life, and also so yes, it's a combination of underlying medical diseases and age that we're seeing also.
And are you aware of any conditions that males might get that might have similar physiological impact?
Now, you're talking about with respect to the pregnancy or?
No.
No.
No. I'm still women have. No, just so that the males on the committee might have, and I know you're dealing with a whole different system, but I'm not aware of any condition that we as males might get that would have such a
Oh, I see your question.
impact on us.
No, sir. Unless you did marathons or Ironman or something like that, things I can't really think of a physiologic condition that's comparable to that. Yes, sir.
Other than kidney stones, I understand that.
Kidney stones are really bad.
Close
Yeah.
to birth, but do members of the committee have questions? Turner Ford.
Thank you, Mr. Chairman, and thank you, Dr. Tucker. When is a typical postpartum patient in the private sector released?
So typically, historically, the postpartum visit was at 6 to 8 weeks postpartum, and released from a medical standpoint at that point. Now, release back to work and all, depends on lots of different, HR issues and the like. So historically, for most of my career, that's been kind of what we have done. About 7 or 8 years ago, when ACOG president, Dr. Haywood Brown from Duke University, one of his presidential initiatives was what he called the 4th trimester. We divide pregnancy into 3 trimesters, first, second, and third. And he said, look at postpartum as a 4th trimester, and it shouldn't end at that 6 to 8 weeks mark. That patients should probably be seen at 2 weeks, then again at 6 weeks, then maybe again at 90 days. And depending on what's going on, for instance, if she was at risk for diabetes, perhaps that patient should be seen again at 6 months, a year to address those things. So historically, 6 to 8 weeks, but from a, I guess, more proactive approach, we're trying to swing that pendulum more towards a longer release point from a medical standpoint.
When would a treating obstetrician have, I would say, a reasonable degree of certainty that a female or a mother has recovered and these organ systems that you've mentioned have returned to normal?
Yeah, so that's a great question, and I think first of all, in general, if somebody is low risk, and let's say that she sailed through the pregnancy, her glucose screen was normal, she had a normal pregnancy, a normal delivery, her blood pressure remained normal, she didn't have any lab abnormalities of concern. Now, I think you can have a reasonable degree of medical probability, a reasonable degree of certainty at her 6 weeks checkup that if all being equal, that things are back to normal. Now, if you took her to a lab and did tests and some of the things I talked about, would you find some abnormalities? Perhaps, but those probably wouldn't be clinically significant. And let's contrast that to the patient who's hypertensive during pregnancy, that perhaps she had to have a preterm delivery because she had severe preeclampsia and her blood pressure has been difficult to control. And at 6 weeks, she's still on an antihypertensive medication where she wasn't on it before pregnancy. That's a whole different set of circumstance that I think, once again, intuitively, you don't have to put her through any test to know that her body is still suffering the effects of that pregnancy. And she obviously is going to take some more time, whether that be days, weeks, or perhaps months. And there's a rare person that, never gets over their hypertension. And that person obviously would need long-term care, usually in the hands of internists.
Thank you.
Any other questions? Carlos, we have any committee members online with questions? All right. Doctor, I have just one last question. We talked earlier about presumptive eligibility, and that a lot of our women here don't get on till aren't seeing care until the 2nd trimester. Just a quick comment about earlier intervention.
I think Dr. Henderson did a great job of that. The only thing I would add to what she said earlier about the importance of prenatal vitamins, folate supplementation, getting baseline labs, checking blood pressure and the like, it's so important to date pregnancies early. Because we have the ability to get a very accurate due date on somebody if we see them in the first trimester. We can get it down to within just days. And that's so important when we deal with prematurity, so important when we deal with delivery at the end. So I think that's another thing that I would add to what she said earlier. That first trimester is so important in getting these baseline things. That circle that I talked about earlier is so important. So.
Senator Wiggins.
Thank you. Doctor, a lot of the discussion, debate around Medicaid is the population's, I guess, desire or demand or ability to get treatment or to be seen. And hearing what you had to say, clearly, I think as most women know, pregnancy is a very damaging and stressful condition on the body. So, but clearly, pregnant women don't always go get it at the right time, I guess I would say. So why is that, or what do you see? And if they don't go in until the second trimester, why? Because hearing what you had to say, clearly, I think that gets shared within the women. If that's the case, why aren't they going? To me, that scares me, and I'd be there right away because I'm a weakling and all that kind of stuff. So why? What do you see?
So I think there are lots of reasons. Some of it, may well be access. It may be something as simple as transportation. Some women honestly don't realize they're pregnant till later. Some of it, I'm sure it has to be, financial. Some of it may be denial. There are some women, and even in my, practice prior to UMMC, who just said, you didn't really do a whole lot for me that first trimester. I just don't want to come up here and wait on you. And I'm going to start my prenatal care at 20 weeks. So I think that there is no single answer to your very good question. I think it's quite complex. A lot of it, is some of the social determinants of health and the like. Some of it's by choice. Some of it's financial. And it's, like everything else in healthcare, the answers are not often, clear. They are complex.
Could there be a better job done at educating women and pregnant?
Absolutely. I mean, whenever there's a problem, I always look inward first and say, how can I do better? And how can the healthcare system do better? And, education on any level can always be improved, and we could do a better job, of that.
Okay, on that note, with what we've heard about preterm births and all that, and obviously we have to look at it, but could we as a state do better educating the populace, so to speak?
Yes, and I think if you put slides up there and the things we've talked about this morning, I mean, even maternal deaths, every maternal death is tragic, and especially if it's you or your family, it is tragic. But when you lump these things in and you just have numbers, that doesn't resonate with people like when you talk about some of the things Dr. Henderson talked about, some of the things Dr. Edney talked about. And I think, educating people as to the harm it does to individuals, the harm it does to families, the tragic nature of it, putting stories and faces to this, I think that would be a very useful educational component to this.
Thank you.
Thank you, Dr. Tucker. Appreciate it.
I think Becky has the physiology quiz you're going to pass out next. Is that right?
And Senator Wiggins, I think in addition to what Dr. Tucker mentioned, I think we can probably take a look from a department standpoint, how we handle this transition with presumptive eligibility to actually get these women approved. Take a look at that flow process and see if we can improve on that.
Meaning getting the word out ahead of time? or-
Getting the word out, maybe simplifying the process and expediting the process.
Well, and it seems like better education too. I mean, that seems to, that's in part, that's why we have a Department of Health,
Right.
you know. from
And
that
that's also why
standpoint.
we have managed care, which,
Amen.
we had hearings a couple of weeks ago on them. And just to get into it, from listening to the other states, I think some of them, one, do a better job of holding these MCOs accountable for the services. And then I also think some of the departments seem to make it easier. They realize they're in the customer service business and make it easy on the beneficiaries to access services. That's just my takeaway from those meetings.
Thank you for the opportunity.
Thank you. Next up, we have Dr. Famudi, who's the Director of the School of Medicine, Department of Pediatrics, UMMC. Dr. Famudi, how you doing?
I'm doing well.
Good.
You did real good with my name.
I'm sorry?
You did real good with my name.
Well, thank you. You may proceed.
I am Mobolaji Famwide. I'm a neonatologist. A neonatologist is a doctor who's a pediatrician and has extra training taking care of babies in the newborn ICU. I always tell people that these hands are small because the good Lord made them to take care of babies. So I do not know anything about big people, but I know the effect of what happens when things don't go right during pregnancy. So I'm just going to share with you real life experiences that I see in our newborn ICU. The newborn ICU at UMMC is the only level 4 NICU in this state. So a level 4 NICU is the highest level of care for newborn care. And we take every baby. We do not turn any baby away. So all the high-risk mothers that are in Chula, Mississippi, or in Gulfport, Mississippi, or up in Tupelo, Mississippi, that get referred to Dr. Dr. Tucker, end up with us in the newborn ICU. Next slide, please. Oh, there's a clicker here. Great, thank you. So disclaimer, I am one of those older women that Dr. Tucker talked about. I chose to delay pregnancy and raising a family for personal, medical, and career reasons. So when I had my baby, I was 37 years old. He came early at 34 weeks because I had fibroids. When you don't use that uterus, something else takes the place of the baby. So fibroids were growing in my uterus and my baby came early. I also had gestational diabetes. I know it's gestational because I had adequate care prior to pregnancy and I knew I wasn't diabetic before pregnancy. I was lucky, I breastfed him for 19 months with support of the lactation team at UMMC, even though I had been a neonatologist for about 7 years. When I had him, I still needed lactation support. So these are the things that I was able to get because I have insurance. I had knowledge, information like you were talking about, and I did what was necessary to make sure I had a perfect outcome. So we'll start with this case one, a mom with pre-existing hypertension. I should add that the average age of the mother delivering in our NICU or with a baby in our NICU is in the mid-20s and not the young teenager that people think about that are the highest risk, although we're now starting to have more and more older moms who are having babies with assisted reproductive technology. The average age is between 24 and 26. So she's been pregnant twice. This is her second pregnancy. In the first pregnancy, she had preeclampsia. Dr. Tucker talked all about that. And her baby had to be delivered at 32 weeks to spare her life. She came late to prenatal care, another thing that's been talked about. She came at 18 weeks. And at the very first visit, hypertension was diagnosed. Got progressively worse, but this time around, there was significant acceleration. And at 23 weeks, 24 weeks, the baby had to be delivered because the baby wasn't doing well. Dr. Tucker talked about the placenta. That's what takes food and nutrition to the baby. and the mom was in pulmonary edema and congestive heart failure. If this mom had had adequate prenatal care, preconception care, if she had seen her doctor and followed up appropriately after that first pregnancy, the hypertension would have been under control. I am not saying that the hypertension will not exist, but the hypertension will have been well controlled. If the hypertension is well controlled, the likelihood of her having to be delivered by emergency C-section at 26 weeks and a baby that's impaired at delivery will be much less. Case 2 is pre-existing diabetes. Dr. Tucker talked extensively about this. This is a 35-year-old mother. This is her 4th pregnancy, all her life, big babies. But nobody's ever told her that she's diabetic or she had gestational diabetes. As a neonatologist, I can almost conclusively tell you that this woman has had this for a long time. Big babies and someone as small as me, it just doesn't add up physiologically. The last baby, when she had her last baby, she had an abnormal glucose tolerance test, but she did not follow up post-delivery. I will tell you in my own case, after delivery, I had to see my doctor at 2 weeks, at 6 weeks, and then at 6 months, I had to do the glucose tolerance test again. And then at 1 year, I had to be followed up just to make sure that I haven't moved into the diabetes range. Most women are not knowledgeable, and if there is no access to care after those 60 days, they don't go on to follow up. And they're walking around with diabetes without knowing that they have diabetes. Diabetes is especially very, very toxic to the newborn, because by 4 to 6 weeks, when the heart tube is forming and glucose levels are high, it is very teratogenic, very toxic to the developing cells. We know, and epidemiologic data shows, that there is a high burden of congenital heart disease in Mississippi. I am almost conclusively sure that diabetes undiagnosed is one of the reasons why we have that. This pregnancy's prenatal care started at 12 weeks. Her hemoglobin A1C was 12. For those of you who know what that means, the American Diabetes Association recommends a hemoglobin A1C around 6. It was 12 in this mother. So her baby had a complex congenital heart disease. And unfortunately, the baby had to have heart surgery, which comes with its own risk, not just for the baby, but for the family as well, because they have to be there with the baby. This is another example of where preconception care, postpartum care, preconception care would have made a significant difference. Postpartum depression, I put this here just to help us see that beyond just the baby and the mom, there is an economic impact when postpartum care is not adequate. This 28-year-old mom, this was her second pregnancy. She lost the first one at 24 weeks. She had preeclampsia. The baby didn't survive. She had an adequate interpregnancy interval, but there was no follow-up. So she probably was already in depression following the death of that very first baby, but she wasn't following up with anybody. Nobody was taking care of her. She wasn't on any antidepressants. She had this baby at 39 weeks, but she was anxious, extremely aggressive towards staff. And anytime anyone said anything to her, she was on edge. This is depression showing its face. And how does that impact the society? How does it impact the workforce? Everybody has heard what's going on in healthcare and the staffing issues, not just in Mississippi, but across the country. We have a bunch of young ladies in the NICU that are awesome nurses, but they are young. They have not experienced life. They do not understand what it means when a mom comes in with postpartum depression and is unable to bond with her child, does not know what it takes, does not have what it takes to bond with the child. Well, that nurse doesn't want to come back to work the next day because what she's thinking in her mind is, I'm doing my best to take care of this baby, but this mom is just aggressive and pushing me away. When I lose that one nurse in the NICU, that is 4 to 3 baby assignments. And if those 3 babies, I do not have the expertise of a nurse who many of us don't think about feeding as something that needs specialized skills. Those nurses are skilled in the art of feeding a baby that came 13 weeks early. That one nurse, 3 babies, I'm unable to provide what needs to be done for them. That increases the length of stay, right? Increased length of stay means increased cost, increased risk of exposure to infection because the home is the best place to be, not in the hospital, despite all the hand washing we do. So this just shows that it's not just the health impact, but there is an economic impact. When the nurses leave the NICU because a bunch of aggressive moms are pushing them away. Screening for by perinatal psychologists is done in our NICU, and that helps us. We've been able to identify so many mothers and to help them get care while their baby is still within the NICU. What happens after they leave, I cannot speak to, but we had many of them come back again because they were lost to follow up. This is a tragic case of a mom who was 22, 6th pregnancy, 4 babies, 2 sets of twins in the last 4 years. There was still 1 set of twins in the NICU. They were delivered at 25 weeks. They had multiple complications of prematurity. At around 9 months, the lady revealed to me that she was pregnant because I saw her and I said, "You look rosy, you look good. What's going on? Tell me the good news." She was ashamed, but she did tell me, "I'm pregnant again." This lady ended up with 2 sets of twins in our NICU. So we had baby doe A1, baby doe A2, and then we had 3 and 4 within the NICU, all at the same time. Every neonatologist is sad when this kind of a situation happens, because we know beyond the health implications, there's the long-term neurodevelopmental implication of this. A baby who's been in the NICU for 9 months, no matter what we do to sustain life, will have some neurodevelopmental impairment. This mother had four of that she had to take home. And they all went home with assisted technology, a G-tube, a trach. That means a ventilator in the house. That's a breathing machine, a feeding pump. There is no way she can have life outside of taking care of these 4 kids. These are real life examples, and I just wanted to bring it home and let you see that it's not abstract things that we talk about. The NICU at UMMC takes in about 1,000 babies every year. And we are thankful that our survival rates, when we are benchmarked with other NICUs across the country, is in the upper percentiles. We do a good job. We keep these babies alive, but it will be wonderful if we started with healthy babies that come from healthy moms. Thank you for the opportunity to speak to you today and for all that you're doing to support the newborn babies in Mississippi, the future of Mississippi.
Thank you, ma'am. It's interesting that all your cases are multiple deliveries. I mean, this is their 2nd or 3rd delivery. So what is, or how are we failing these women, I guess, in the education, going back to Senator Wiggins? If they've already had a baby, now they're there with their 2nd baby and they're there late and they're still not following through. What can we do to help them?
My suspicion is that after the 6 weeks follow-up with the OB, they lose the insurance and they think they're all clear in the absence of an emergency like we have now. They think they're all clear and they are not knowledgeable, do not know Number one, many of them did not know about the emergency declaration and how they can continue to receive care. But even outside of that, they do not know. So that is why I strongly echo that a public health campaign to help these mothers see that pregnancy is a beautiful thing. It brings forth life. But at the same time, it is a very stressful situation and has long-term implications, not just on them, but on their offspring, their future offspring. I think that intraconception care and what happens in the postpartum period, we need adequate and effective public health campaign to support that.
I understand you guys have about, on an annual basis, about 1,000 patients that go through there, and 25% of those are 3 pounds or less. So that would fall into that minimum or an average $600,000 treatment. That's over $150 million that we're spending. So do you think maybe with some postpartum care and some education and extension to 12 months, we might be able to reduce that cost a little bit?
That's my hope. If we treated that mom with anxiety and depression and she did not run off all the nurses taking care of her baby, I will have more nurses to be able to feed those babies and get them out of the NICU quick. If that mom did not go into overt diabetes, or her diabetes was treated and her child did not end up with a cardiac lesion that needs, life support and major surgery, that baby will be a healthy baby going home, just like mine. I had gestational diabetes, but he's healthy, running his mouth at St. Andrews right now. If that mom with hypertension did not need to be delivered at 23 weeks, I won't have that baby in the hospital for 9 months. Definitely economic implication of all those things.
Do other committee members have questions? Senator Polk?
Thank you, Mr. Chairman. Thank you for being here today. Your case studies were interesting. And I think we've begun to talk a lot about education. And I think a lot of younger women see pregnancy and the birth of a baby as a wonderful, beautiful time, that nothing goes wrong and the world's a happy place and the babies are all fine. Do we show younger mothers in our education system, younger women, do we show them what can happen? Or do we paint too rosy of a picture of how fun having a baby is? Do we do enough education to say things can go wrong and you need to know this? And then secondly, on top of that, after a baby is born and it's in the NICU, that's to me the perfect place to say to mothers, help us, tell your friends, you yourself need to understand that this can happen again. Do we do any education like that at UMC?
I'll speak to the NICU first because that's my world. Perinatal psychology is something that's absolutely necessary in the NICU. It's not just the moms that are depressed. About 24% of fathers who have babies in the NICU go through depression, and a high rate of families break down while their baby's in the NICU. The funding we have now for perinatal psychology is through a HRSA grant. We do not have psychometrists that can bill and be paid for to take care of those moms. We are using grant funding. So that is an opportunity for us in this state to help to provide the structure and the system that will integrate that in the NICU. The NICU at UMMC is 1 out of 13 NICUs in the state. Well, I guess 11 now. NICUs in the state. And I can tell you categorically that we are the only one with a perinatal psychologist. So things that can be done while the mom is in the NICU, we are hampered because we do not have the support and the infrastructure that's robust enough to be able to do all that we want to do. I honestly cannot speak to the school system, but I know that pediatricians do counsel teenagers when they come in to see them for their EPSDT screening. They have those discussions with them, but I cannot speak to what happens in the school system. But I will say that in the NICU, there's still more work that can be done. That 9 months or that 3 months, or even that 6 weeks while that baby is still in the NICU, there's so much more that we can do and that we want to do. I can speak to the NICU at UMMC that we want to do, but we just do not have the resources to be able to do it. We're thankful to HARSA because we got that grant and we have the system and structure in place that not only talks to them and takes care of them in the NICU, but when they go home in our follow-up clinic, we have that support structure for them while the funding exists.
Any other questions? Carlos, do we have anybody, committee members online? Dr. Famudi, thank you. Appreciate your presentation. Thank you. Next up, we're going to have Will Irwin with the Mississippi Division of Medicaid.
Thank you, Mr. Chairman, and good morning. My name is Will Irvin. I am the Deputy Administrator for Health Policy and Services for the Mississippi Division of Medicaid. I have been given the unenviable task of filling in for Executive Director Drew Snyder today. I say unenviable because while it is an honor for me to be here with you this morning, I know how much respect many of you have for Director Snyder and that I have very big shoes to fill. So I do ask for your grace and patience as I attempt to do that today. I know Director Snyder wishes he could be here with you all today, and he did ask me to send his regrets that he was not able to do so. I don't have a presentation for you all this morning, just some prepared remarks. I know that you've been given a lot of really good information and heard from a lot of qualified experts this morning. I don't have a lot to add. So I'll try to keep these remarks fairly brief. This morning, I'd like to present the committee with some information that I believe will help inform the decision of whether or not to extend Medicaid coverage for postpartum mothers beyond the current 60-day postpartum coverage period. And I believe Director Snyder has shared some of this information with several members of this committee previously, so I apologize in advance for any information that may seem repetitive. But I do think these are important details to provide some context to the current discussion. My goal today is to provide impartial information to the committee without any intention of influencing opinion in either direction. And just for reference, throughout these remarks, when I refer to postpartum extension, I am referring to extending full Medicaid benefits for postpartum women from the current policy of 60 days to a full year. And this morning, I thought I would begin by describing the Medicaid coverage policy for pregnant women as it existed prior to the COVID-19 pandemic. Pre-pandemic, pregnant women with household income up to 194% of the federal poverty level qualified for Medicaid for up to 60 days after delivery. For reference, 194% of the federal poverty level for Medicaid, 194% of the federal poverty level is about $4,603 per month for a family of 4. Pregnant women under age 19 can qualify regardless of income. Before the pandemic, these individuals were automatically enrolled in the Medicaid family planning waiver after 60 days postpartum if they did not qualify for a different full-service Medicaid category of eligibility. The family planning waiver is a limited benefit category of eligibility that offers mostly family planning related services. Covered services through the family planning waiver include 1 annual visit and subsequent visits related to birth control methods and family planning services. Beneficiaries cannot exceed a total of 4 visits per calendar year, and beneficiaries in the family planning waiver are generally not eligible to receive any other Medicaid benefits. The Families First Coronavirus Response Act, or FFCRA, changed Medicaid eligibility policies by requiring state Medicaid agencies to maintain coverage through the end of the public health emergency. I'll refer to that as the PHE from here on out. And that's for individuals who were enrolled in Medicaid on or after March 18th, 2020. That's a condition of receiving a 6.2 percentage point increase to the federal match rate. Since that time, pregnant women who were enrolled on or after March 18th of 2020 have maintained full Medicaid coverage and will continue to receive full coverage through the end of the PHE, essentially enacting a temporary postpartum extension policy through the end of the PHE. Though, to clarify, continuous coverage during the PHE is not limited just to pregnant women. Right now, the public health emergency is scheduled to end January 11th, 2023, but current indications are that it will be extended for at least another 90 days. Based on the most recent Medicaid enrollment data available, there are around 160,000 more individuals eligible for Medicaid now than in March 2020, when the continuous enrollment requirement began. Before the pandemic, the number of individuals in the pregnant women category of eligibility consistently hovered around 13 or 14,000. Since the continuous enrollment requirement was effective, that number has climbed above 45,000. So based on that information, I assume that approximately 32,000 individuals in the pregnant women category of eligibility have retained full Medicaid coverage as a result of the continuous enrollment requirement. I imagine, but can't say for certain, that this number is a little higher than the number of individuals whose eligibility would be positively impacted as a result of a permanent postpartum extension, since the continuous enrollment requirement has been in place for more than 2.5 years. Initial estimates suggest that extending postpartum coverage for 1 year would cost roughly $32 million total. So that includes both state and federal spending. The state share is projected to be a little bit more than $7 million. Obviously, that cost would be lower if the decision was made to extend postpartum to 6 months rather than a full year. The estimated cost of a 6-month extension is around $13.4 million total, of which $3 million would be the total cost of the state. It's my understanding that the federal match rate for extending postpartum coverage is the same as the regular medical match rate, which currently is around 84%, but is expected to drop to about 77% when the COVID continuous enrollment enhanced match rate is discontinued. So what impact will postpartum extension have on health outcomes for postpartum women and their newborns? That's a great question, and I believe a very important one. I think the short answer is we, as in we, the Division of Medicaid, don't know. There seem to be some very sharp people that think postpartum extension will positively impact health outcomes for pregnant women, reducing the maternal mortality rate, improving the mental health of postpartum mothers, and a number of other things that I'm probably forgetting that could positively impact the ability of the mother to care for her newborn child. There may also be some academic studies that have looked at that, though I'm not immediately familiar with any. For our purposes, and I know Director Snyder has mentioned this previously, we think that we may be able at some point to draw some conclusions from public health statistics during the COVID continuous enrollment period. However, with the impact of COVID in 2021, it may be difficult to read too much into the 2021 statistics. 2022 data will likely be more applicable, but with a 1-year timely filing allowance for providers to submit Medicaid fee-for-service claims, that means we won't really have a good idea and a full Medicaid data set for calendar year 2022 to look at until probably the first part of 2024. According to the Kaiser Family Foundation, and I believe Dr. Henderson presented some of this information earlier, 27 states, including the District of Columbia, have implemented a 12-month extension of Medicaid postpartum coverage. Another 7 states plan to implement a 12-month extension. 2 states, Texas and Wisconsin, have proposed or adopted a more limited extension of postpartum benefits. I believe Texas has implemented a 6-month postpartum benefit and Wisconsin's is 90 days. From a policy framework perspective, states historically have been required to submit an 1115 waiver to extend postpartum coverage beyond 60 days. However, the American Rescue Plan Act created a pathway for states to extend postpartum coverage through a traditional amendment to its state plan, which is the detailed agreement between the state of Mississippi and the federal government that describes the nature and scope of Mississippi's Medicaid program. This pathway to coverage is less burdensome administratively, though it often provides a little less flexibility. There has been some suggestion that Medicaid can extend postpartum coverage without legislation. Full disclosure, I am not an attorney, and I cannot say with certainty whether legislation is absolutely necessary to accomplish that change legally. Mississippi Code Section 4313-115 specifies the requirements for Medicaid eligibility, and I imagine a change to that statute may be necessary to extend postpartum if for no other reason than to proactively address any potential ambiguity or conflict with current Medicaid eligibility law. I know that there are many learned attorneys here in the room today, and some of you may have an opinion on that. But what I can say fairly confidently is that the division at this time does not intend to act unilaterally to extend postpartum coverage, even if the current legal framework allows the division to do so. So in that respect, I personally do believe that legislation is needed to accomplish the change. I think as most of you know, the Division of Medicaid has not taken, and today I'm not prepared to offer a position on postpartum extension. Our focus is on responsibly providing access to quality health coverage for individuals who are currently Medicaid eligible. If the legislature chooses to extend postpartum Medicaid coverage from 60 days to 6 months or 1 year, that focus will not change. We will continue to strive to make Mississippi's Medicaid program the best it can be for beneficiaries, taxpayers, providers, and other stakeholders. The division does, however, respectfully ask that if the legislature intends to extend postpartum coverage, that you do so quickly and decisively, and by doing so, give the division enough time to successfully implement the change. That you allow the division the flexibility to implement this coverage change through either an amendment to the Medicaid state plan or through a Medicaid waiver, and that consideration be given to requests made by the division to financially support the change. And with that, I hope that I've already answered many of the questions that you may have had, but I'm more than happy to try to answer any additional questions. And I will commit to you that if I can't answer any particular question today for whatever reason, I'll take that back to the team and get you an answer as soon as possible. Thank you again, Mr. Chairman.
Thank you, Will. And you shouldn't undersell yourself. Your reputation precedes you. You're well respected. Thank you. On the extension of benefits, that's not a expansion, is it?
Those are two different things. And I believe Dr. Edney spoke to this a little bit this morning. Medicaid expansion, as it's typically discussed, refers to expanding Medicaid up to 138% of the federal poverty level for what are traditionally considered non-disabled childless adults. That was enacted under the Affordable Care Act. What I believe that we're discussing today with the postpartum extension refers to extending benefits for pregnant women from beyond 60 days postpartum to either 90 days, 6 months, a full year.
Extension in the way you just framed it is basically changing the eligibility requirements, is it not? If we were to look at Medicaid expansion, it changes the current eligibility requirements to expand.
Medicaid expansion would require a change to current eligibility policy. Extension could potentially to allow those individuals to remain on beyond 60 days. But again, I think there's a little bit of ambiguity there with the current legal framework of whether or not that would absolutely be required.
Right, but under postpartum extension, what we're talking about, extending it from 60 days, it's not going to change any eligibility for these women, is it? The women, basically
If I
the
understand
women.
the question correctly, I don't believe it would be any new people that would be enrolled. It would be current pregnant women who already have Medicaid that would continue to receive that for an extended period of time. Now, there would be some new folks that could potentially benefit from that as they become pregnant, but we're not talking about a new category of eligibility.
That's correct. And we're not talking about changing any of the criteria for the current eligibility, are we?
That's my understanding. I don't think that there's been any discussion of changing eligibility criteria for pregnant women.
The women who have been on, I guess, everybody got transitioned to fee for service, moved off of the managed care after the 60-day period.
There were some individuals early in the PHE, after the continuous enrollment period, that were transitioned into managed care. I'm not sure how many of those were transitioned from fee-for-service into managed care, and I'm not sure that it was just specific to pregnant women. If I remember correctly, there was a period of time during which individuals who no longer met eligibility criteria to be on Medicaid absent the continuous enrollment requirement, those individuals were transitioned from managed care to fee-for-service. I'm not sure that that practice is still going on, and I'm not sure when that changed.
I thought it was through the PHE, the requirement was after the 60-day period, they're transitioned to fee for service, and that the department actually sent out letters of termination. And then later on would send a letter saying, now you can enroll in the fee for service program.
The continuous enrollment requirement essentially requires the division continue to provide Medicaid services to those individuals. It's not really spoken, at least in my understanding, to whether or not they needed to be in fee for service or managed care. There were some individuals who were transitioned early on. I think that that's not happening anymore. I'm not sure if that answers your question or not.
Would you happen to have any utilization numbers for women for their visits that have continued after that 60-day period?
We don't, and again, with looking at Medicaid data, we're about a year behind whenever it comes to looking at claims utilization, because all of our information is claims driven. And we have that 1 year provider filing, timely filing allowance. So essentially, if you have an individual that goes in for a doctor's visit on December 31st of 2020, a physician has until December 31st of 2021 to file that claim. So you're looking at a pretty significant lag with that data. I don't have any information in front of me today on utilization, and I don't think that we have necessarily any for that time period yet.
All right. Any other questions from the committee members? Senator Polk.
Thank you, Mr. Chairman. Morning, Will.
Good morning.
Glad to have you here.
Glad to be here.
In your closing remarks, you sounded a lot like my second favorite TV show, Blue Bloods. And they're always doing stuff post-haste. And I believe you just, in your closing remarks, said if we chose as a legislature to extend postpartum, that we need to do it post-haste. Is that what I'm understanding?
Yes, sir. And I believe Director Snyder has mentioned this before. We would just ask if the legislature intends to move in that direction, that you do so quickly to allow the division enough time to successfully implement the change.
All right. During this COVID emergency, has not postpartum been extended to a year now by the federal government or no?
It's essentially extended through the end of the public health emergency. So
Okay.
it's almost like a temporary postpartum extension that will end at the end of the PHE. So it's even more than a year for some individuals currently.
Okay, so does that not mean that the apparatus in Medicaid division is there to do this already? You're doing it, so it's not something new if we did that?
Theoretically, are you talking about from a legal perspective or
From an operational perspective more than anything?
Operationally, I think so. I'm not sure what the lift would be to keep these individuals on longer term. There's some considerations about transitions to managed care because pregnant women are traditionally covered under Medicaid managed care. But essentially right now we are providing that benefit.
So post haste to get it done wouldn't necessarily change what you're doing now. As long as y'all are
I hate to say-
operationally doing it.
I hate to say no without taking that back to the team, but I see what you're saying. It does seem like it would not have a huge impact on current operations.
I think that answers the question. Thank you, Mr. Chairman.
Senator Wiggins.
Thank you. Thank you, Will. I think there's some confusion at least, and I want to try to clear some things up. So and this goes to Chairman Blackwell's point about extension, not expansion, extension of the postpartum. So Medicaid, when you strip it all away, is actually just an insurance program, correct?
I would say that's correct.
Okay, so in the private market, you have insurance companies like Blue Cross and Aetna that provide insurance plans that they make a determination of what they're going to pay for, correct? In the private market.
I would agree with what you're saying.
Okay, and then effectively in the public market, for those eligible, which are your low income and mothers and all, you have Medicaid, which is that insurance program, right?
Yes, sir. We have Medicaid for low income parents.
And then going to your point about us, the legislature, deciding what should be covered, that ends up being our job because Medicaid is set out in statute. And so whereas in the private sector, they go, well, you know what, we've looked at science and we say we're going to make this decision. But in Medicaid, that's our decision. That's what you're saying.
I would agree with that, especially a decision of this scope and magnitude.
Okay, so in the private sector, in the private sector, they have open enrollment every October, basically, to say, hey, come get into the health plan that we're offering, and here's what we're covering through the health plans, correct?
I don't know for private insurance what the open enrollment timeframe is. I know with our managed care companies, there is an open enrollment period from October through December.
Okay, so what gets covered is a factor of science and what has been determined over time, and also the cost. Would you agree with that?
Yes, sir. And a lot of the coverage is outlined in Mississippi Code Section 4313-117, what we traditionally refer to as the tech bill. That outlines a lot of what we're prescribed to cover.
Right,
I think
okay.
that goes to your point that a lot of it's outlined in statute.
That's kind of Medicaid's coverage brochure that they do in Blue Cross and Blue Shield. I kind of equating the two.
I think that's a fair.
Okay, so what all we're doing is based on what we have heard through both the Women and Children's Committee and this committee, every doctor I've talked to, every presentation I've heard, they have said for the benefit, based on the science, for the benefit of the children who are on Medicaid or who are eligible for Medicaid on postpartum, and the mothers, by the way, I should say, this from a health perspective, this is a smart thing to do. I mean, y'all have heard that, correct?
We have certainly heard other
Okay.
experts attest to that. Yes, sir.
Okay, so in the private sector, that's what they look at is what is health-wise, what is going to benefit are covered, and then what's the cost? And so we have to look at what the cost is. When you're talking about this 6-month to 12-month and the PHE, we're not talking about, are we, that a person will end up, if the PHE goes on for 2 years, they're not going to be eligible for 2 years because postpartum is not going to go on for that long. Does that make sense?
If the PHE continues, we won't be able to disenroll anybody until the end of the PHE. So the longer it goes on, the longer we'll keep these individuals who have maintained coverage on.
But I guess what that means is that's only applied to somebody who's had a baby, okay? Right? Who's eligible for Medicaid.
Well, with the continuous enrollment requirement is for everybody who is enrolled as of March 18th of 2020. It's not just specific to pregnant women. Pregnant women have benefited from that, if you will.
Okay.
But it's not just limited to pregnant women under the PHE.
Okay, but what we're just talking about is the postpartum extension,
Right.
That's all we're
which
talking
is
about.
limited to pregnant.
which is only related. So we're not extending the PHE and adding benefits. We are making a decision about what is in the best interest health-wise of our pregnant beneficiaries and the children, just like an insurance company would make a decision about that.
I think that's fair.
Okay. And so if that decision is made by the legislature, which is what you're saying, then y'all will carry that out like you do everything else that's in the code sections, right?
Absolutely.
Because it's our decision as the legislature to make it.
Yes, sir. If the legislature decides to move in that direction, we will execute it as efficiently and effectively as possible.
And last session in particular, the Senate made that decision and the House chose not to do it.
That's my understanding.
So the House's decision to not do it is the decision to keep these children and these mothers from having this care that all of our scientists and doctors and health professionals say is in the benefit of our families.
I certainly can't speak to the intention of the House of Representatives, but
Oh, come on. I understand that. Okay. So if we were to say, okay, we are going to allow or direct the Division of Medicaid to cover this, and let me back up. When I say that, we, the legislature, direct the Medicaid to cover medications, to cover hospital expenses, to cover that, right?
correct.
Okay, and y'all carry that out.
We do.
Okay, so if we direct y'all to do that, has there been do we know what the cost of that is going to be? Or has that been calculated?
Yes, sir. For a full year extension, we're looking at about $32 million total, and it'd be a little bit more than $7 million in state support.
Okay, it'd be what?
A little more than $7 million in state support.
Is that because of the amount of beneficiaries that would be covered by that?
It would be the additional period of time during which those pregnant women who otherwise would not have had coverage would remain on the rolls.
Okay,
Because otherwise they would have rolled off after 60 days. This is just taking into account the additional 10 months that they would be enrolled in the
Okay.
services that they would obtain. during that
Okay.
time.
so have we calculated the cost? So what we've heard is if you do it now, you pay now to save later. Have we calculated the cost, what that savings will be later on?
The division has not. I think that there were some people earlier on that suggested that there was an ROI associated with this. We've just simply looked at the cost of what that extension would be. I don't think there's any way for us to necessarily look at what the long-term savings would be per se. I don't know how we would calculate that.
But, okay, but that's what we need. That's what we do anyway when we're making these decisions.
I think it's important to look at potential savings. I just don't know, as the Division of Medicaid, that we can provide you with what that potential savings would be.
Okay. Thank you, Mr. Chairman.
Senator Turner Ford.
Thank you, Mr. Chairman. Mr. Tucker, you mentioned an estimate of 32 million. What is your estimate based upon? What type of care is factored into the estimate?
I don't know the calculation parameters. I don't have that in front of me. That was done by an actuarial firm. I'm not an accountant, and I would hate to even try to speculate because I would butcher that explanation.
And for the women who are benefiting from the extension of care under the CARES Act or affordable, what is it? ARPA, American Rescue Plan. What type of care are they receiving? Are you all in a position to monitor what the doctors are prescribing?
We can see claims data. So whatever the physicians or the pharmacists submit as a claim for that individual, that's the information that we get. As far as coverage goes, they're receiving full Medicaid benefits right now.
I guess what I'm thinking about, or the question is, do we know if doctors are monitoring the patients and saying, I want you to come back after 60 days, 90 days, and then checking them again after 12 months? Do we have any type of idea of how they're managing the patients?
I do not. And I can ask our team if they have some of that information, but I'm not aware of anything like that we have right now.
And this is another question I have, and it's more general. When is the last time Medicaid had a shortfall?
It's been a number of years. I want to say maybe 15 or 16 was the last time that we asked for a deficit appropriation. I'm not sure that we have since Director Snyder has been in charge. And I think the last 3 years or so, we've requested level funding. So nothing has increased in that respect. I don't know for certain, but I know it's been a number of years since we've asked for a deficit appropriation.
And my last question, the 60 days that we are operating under to end or restrict this postpartum care, is that written anywhere? It's not codified? Is that correct?
I don't know of anything in the state statute that says explicitly 60 days, if that's the question. Historically, eligibility has been limited to 60 days. I think at the federal level, though that changed with the ARPA legislation. One of the recent bills that was passed by Congress allowed states to extend postpartum coverage from 60 days to 1 year through a traditional state plan amendment. I think before that, states had to go through an 1115 process, a waiver of statutes, if you will, in order to accomplish that change. Did that answer your question?
It does. Thank you.
Anyone else have questions? Drew, I've just got one final one. Were you here for Dr. Tucker's presentation?
I was here for a little bit towards the end, I believe.
He presented on the basically the health aspects of the woman that pregnancy has on them. I know you're recently married. Congratulations.
Thank you.
Just wondering if you and your wife chose to have a child, would you want your wife to have care beyond 60 days?
If my wife had a baby, I would want her to have the best possible care available.
Thank you. Any other questions? Thank you, Will.
Thank you.
I think next we have Con Nugent from NCSL. She's on the line. All right. Con is the project manager for health programs for NCSL. Con, you are recognized.
Thank you so much, Chairman. And good morning, or good morning still in Mississippi. Thank you so much for inviting NCSL to share our resources and information on this topic, Medicaid postpartum coverage. We're honored to be here. My name is Kai Nguyen. I'm a project manager in the health program at the National Conference of State Legislatures, or NCSL, and I'm joined by my colleague, Catherine Costanza, who is our Medicaid expert. For those of you who are not familiar, NCSL is the only bipartisan membership organization serving all state legislators and legislative staff in all 50 states and the U.S. territories. We do this through nonpartisan research, education, technical assistance, and ensuring a strong, cohesive voice for the states in the federal system. We do not take positions on state issues and do not advocate for or against any state legislation. Today, my colleague and I will provide a brief snapshot of the current national picture for postpartum Medicaid coverage extensions, a brief history of this policy option, a brief review of the Medicaid framework of options for states to implement this, a dive into state policy options and examples of where states currently stand, and a very brief discussion about available outcomes and evaluation data. So to get started, the current national picture. This map on this slide shows the current status of postpartum Medicaid coverage extension across the US. You can see in green that it says 30 states, it's 29 states plus DC that have extended coverage beyond 60 days. They have received CMS approval and are in the implementation stage. The 8 states in orange have pending action and are awaiting CMS approval. All right, and we were asked to just provide a little bit of context about how this policy trend emerged and how, so many states came to adopt it so quickly within just the last couple of years. So we'll share just a bit of history on the early adopters and the data sources that led to the policy being introduced and adopted widely. So some of the early adopters of extended postpartum Medicaid coverage include Missouri, California, Illinois, and Georgia. In 2018, Missouri extended benefits for substance abuse treatment specifically for 1 year. And in 2019, California used state funds to extend maternal mental health coverage for 1 year. Illinois and Georgia extended full coverage, so not specific to those types of treatments, but full Medicaid coverage for 12 months in Illinois and 6 months in Georgia, respectively, at that time. I want to note that these policies were all passed when the only path to extend coverage was through an 1115 waiver, which CMS began approving in 2021. All of these plans have shifted and been updated over the last couple of years, so they don't reflect the current status of coverage in those states, but illustrate the history and the early versions of postpartum coverage extension. But where did this policy emerge from? You heard this morning about Mississippi's Maternal Mortality Review Committee and how they provide recommendations to the state based on reviewing data. Well, all states have some form of maternal mortality review committee, most of which were legislatively created. These are multidisciplinary committees that review maternal deaths to understand the medical and non-medical causes and contributors to death. They analyze data to make recommendations to prevent future deaths and provide reports of their findings to the state as required by statute. Now, this next slide gives some context to how these came to be recommended to state legislatures. The policy recommendation emerged from review of maternal deaths, revealing that pregnancy-related deaths occurred beyond the 60-day coverage period and disproportionately impacting communities with higher Medicaid coverage rates. The data the state review committees analyzed indicated that chronic conditions such as cardiovascular diseases, hypertension, and depression, which often require care over a longer term, made up a large proportion of complications in the year after delivery. The recommendations refer to continuity of care and access to preventive services for low-income women who are at higher risk of developing these conditions. You can see several examples of state review committee reports recommending extending coverage to 1 year postpartum here, and you'll recognize the names of some of the early adopters. This can be found in numerous other states' mortality review reports as well. So with that background, I'll now turn it over to NCSL's Medicaid policy expert to dig into the Medicaid framework and current status of states' postpartum Medicaid strategies.
Thank you, Kine, and thank you, Chairman Blackwell, for inviting us here today. In this section, we're going to discuss how states have leveraged different Medicaid strategies to adopt postpartum coverage. But before we dive into the specific strategies for postpartum coverage, I think it's helpful to briefly review the broader Medicaid framework to understand what that framework is. So in the Medicaid program generally, the federal government sets minimum program requirements in Title 19 of the Social Security Act that states must follow to receive federal matching funds for the Medicaid program. These federal minimum requirements may also include standards for optional programs that states may choose to implement but are not required to implement. The Medicaid state plan is the agreement between the state and the federal government describing how the state implements the federal minimum requirements and any optional programs that the state has chosen to adopt. States can choose to adopt these optional programs in accordance with federal standards through state plan amendments, which are also called SPAs, and you'll hear me refer to them as SPAs throughout. Finally, a Section 1115 demonstration waiver is a written approval from the Centers for Medicare and Medicaid Services that allows states to waive the federal standards or federal minimum requirements or make changes to optional program standards and still receive federal matching funds despite those changes. So how does this work in relationship to postpartum coverage? How does this framework operate? So first, there is the federal statutory floor of coverage that state Medicaid programs are required to meet. And you heard Deputy Administrator Irwin discuss this a little bit earlier. The Medicaid program has covered low-income pregnant women for almost 40 years. And today, all states must cover at least pregnancy-related services for most pregnant women with incomes below 138% of the federal poverty line, and that coverage must extend from the date of birth through 60 days postpartum. States have had the option to increase the income thresholds for eligibility or include other covered services in the benefit package. And as you heard from Deputy Administrator Irwin in Mississippi, I believe he said it was 194% of federal poverty line, and it includes the full benefit package. Yes. So in relationship to the federal minimum requirements, postpartum coverage extensions in Medicaid are just that. They are an extension of the existing package of benefits beyond that minimum federally required 60-day duration. And states can do this either through a SPA, the state plan amendment, or Section 1115 waivers. So when it comes to the state plan amendment, the American Rescue Plan gave states the option to extend postpartum coverage through a state plan amendment and set standards for the package associated with this option. And I'm going to refer to this as the SPA option throughout the rest of this presentation. You're going to hear me say it a lot. States that adopt the SPA option must extend full Medicaid benefits to eligible pregnant women through 12 months postpartum coverage in both the Medicaid program and in the state's CHIP program. Alternatively, states can seek approval for a Section 1115 waiver demonstration to obtain the federal match for programs that deviate from the federal minimum requirements or optional program standards in the SPA option. So before the SPA option became available, the early adopters like Illinois and Georgia used Section 1115 waivers to extend postpartum coverage, and these waivers and packages varied significantly from state to state. However, now that the SPA option is available, the role and use of Section 1115 waivers to extend postpartum coverage is evolving and currently remains unsettled. And we're going to talk about that a little bit more in a moment. So what have states done to date? As you can see, the 23 states in blue and the District of Columbia have extended postpartum coverage through the SPA option. The 7 states identified in green have extended postpartum coverage using Section 1115 waivers. And the 8 states in orange are currently pursuing postpartum coverage extension through one or both of these options. The remaining 13 states in white have not yet extended postpartum coverage. So in total, as Kind mentioned earlier, 38 states and the District of Columbia have extended postpartum coverage or are planning to extend postpartum coverage. So now we'll take a look at what states are doing right now in a couple examples. So first, it's important to highlight the prevalence of the SPA option. Since the American Rescue Plan Act passed in March 2021, 23 states have received SPA option approvals, and at least 5 more are explicitly pursuing the SPA option to extend postpartum coverage. Because so many states have adopted the SPA option, other state policies are easier to compare against the benefit package required by the SPA option. So just as a refresher to dig into more details about the SPA option, it is available to states for the 5-year period between April 1st, 2022 and March 31st, 2027. It may be reauthorized in the future by further federal action, but it's a time-limited option. It is available to pregnant women that meet the state's income thresholds for eligibility and includes all Medicaid-covered items and services for the full 12 months postpartum. And additionally, the SPA option includes continuous eligibility, which means that pregnant women who are eligible will remain eligible for coverage regardless of any change in circumstances that would otherwise affect her eligibility during that 12-month period. Although they can always choose to move to to decline coverage or to move to a different coverage. For instance, if they receive employer benefits at some point in the future. We've also provided some examples of legislation authorizing the use or directing Medicaid agencies to adopt the spot option. So in our state examples, interestingly, some states that were early adopters of postpartum coverage extensions through those Section 1115 waivers have since withdrawn their approved waivers and have transitioned to the spot option. In the case of Georgia and Indiana, their original Section 1115 waivers were either for a shorter duration or a more limited benefit package than the spot option would permit. In our next state, Alabama is an example of a state that is currently in the process of pursuing the spot option as a direct result of findings and recommendations from its Maternal Mortality Review Committee. And its committee found that 55% of maternal deaths were preventable. And of these deaths, 75% had an actionable policy lever to address the cause of death. And postpartum coverage extension was one of the actionable policy levers identified by this Maternal Mortality Review Committee. And next, Texas and Wisconsin may provide insight into how Section 1115 waivers may be used to extend postpartum coverage in a more limited manner than is otherwise available under the spot option. So both states have sought approval for a postpartum coverage package that is less than what is available in the spot option. And these waivers are currently pending, but they have not been approved by CMS. So Texas currently has 2 waivers pending. The Texas Healthy Women waiver was submitted before the spot option became available in 2020 and provides limited benefits to address certain conditions, including substance use disorder and cardiomyopathy, based on the findings of Texas's Maternal Mortality Review Committee. More recently, the Texas Healthcare Transformation Quality Improvement Program, which is a mouthful, was submitted in May 2022 after the spot option went into effect and extends full benefits 6 months postpartum. If one or both of these waivers move forward, it's likely that CMS and Texas will work together to choose which components of the waivers will be implemented, given that they conflict somewhat in their terms and packages. Wisconsin's postpartum coverage extension was also submitted in 2022, and it extends full benefits 90 days postpartum, but limits eligibility for the additional 30 days only to pregnant women with incomes at or below 100% of the federal poverty line. Wisconsin's income eligibility threshold for pregnant women is at 300% of the federal poverty line. So the extended 30 days of benefit would not include pregnant women between 101% and 300% of the federal poverty line who are otherwise eligible and receive the minimum federal benefit that is required. So because these are pending, the status of Section 1115 waivers in postpartum coverage is in flux. If CMS approves or rejects either Texas or Wisconsin's waivers, it will provide states with more information about the scope of benefits and duration that CMS may approve in Section 1115 waivers in the future. And now my colleague Kine will walk us through some preliminary information about outcomes and evaluation data related to postpartum coverage extension.
Thank you. Yes, so to wrap up, we just wanted to share where things stand with outcomes and evaluation data. As you heard, evaluation data in terms of health outcomes following passage of the policy in different states have not been released yet because the policy changes have been within the last couple of years. The spot option went into effect this year, and even with the early adopters or the continuous enrollment provision under the public health emergency, evaluating health outcomes post-policy typically takes time, allocation, and peer review. And rigorous scientific studies will also have to parse out the interplay of increased risk of severe illness from COVID. So we don't have research to share on health outcomes directly related to this policy. But as was part of the history that I shared, the policy emerged from many states' review of maternal death data on timing and causes of death. I did want to highlight that South Carolina specified that their health department and maternal mortality review committee is to develop a method of evaluating the effectiveness of 12-month postpartum coverage, which was also passed in the same bill. I will, however, share a couple of peer-reviewed studies published this year that are not related to health outcomes, but may be relevant to some of the questions you might have on the effect of retaining coverage on enrollment and the effect of extended coverage on access to care and utilization of services. So a question that some policymakers ask is whether eligibility or availability of coverage leads to actual enrollment and continuity of coverage. In a study that looked at data not related to this coverage extension, researchers from Boston University, the University of Michigan, and Columbia found that Colorado women who were eligible for continuous coverage after 60 days postpartum based on income were more likely to stay enrolled in pregnancy coverage, meaning that when women qualified for coverage after 60 days, they were more likely to stay enrolled and continue coverage. Again, this was based on income and looked at data before the coverage extension was available. The second study is perhaps much more relevant and looked at utilization of services following coverage extension. A study released this year from Texas looked at utilization before and after the public health emergency's continuous enrollment provision. Researchers examined a Texas Medicaid health maintenance organization and found that after implementation of the coverage extension, women used twice as many postpartum services, 2 to 10 times as many preventive, contraceptive, and mental behavioral health services, and 37% fewer services related to short interval pregnancies within the first year postpartum. That last number just means that fewer covered beneficiaries returned for services related to a new subsequent pregnancy within the year following the last delivery. So with that overview, we wanted to leave you with some related NCSL resources on this topic, as well as our contact information. And we are so thankful that you invited us here, and we are happy to take questions.
Thank you, ladies. Could you go back to one of your earlier slides and go through the SBA and 1115 options?
Absolutely. And are you interested in the postpartum options or just the broader framework?
I'd probably say the postpartum option.
So to review, the Title 19 of the Social Security Act establishes both the minimum eligibility category, which is pregnant women at a certain income eligibility threshold, the benefits that are required to be covered in that package, and the duration of the benefits. So the federal floor, statutory floor that all states are required to meet is that pregnant women at or below 138% of the federal poverty line must be covered. The benefits must include pregnancy-related services, although 45 states have expanded that to full Medicaid benefits since then. So states typically expand more than that, including Mississippi, I believe. And the duration of the benefits is for 60 days postpartum, regardless of any change in income. The state plan amendment and the SPA option is what we generally refer to, I think, as that postpartum coverage extension. So it is full Medicaid benefits still provided to that same beneficiary category. So pregnant women that meet the state's income threshold. And it's all covered items and services provided for 12 months postpartum, regardless of any change in circumstances. And the change in circumstances includes not just changes in income, but changes in household size and other factors that can also impact eligibility. And finally, Section 1115 waivers, these vary. And so the benefit packages is going to vary depending on what the state chooses. But it's variation from the federal floor or from the SPA option standards. And states have done this a little differently recently. So for instance, we talked about Texas and Wisconsin, and they have requested Section 1115 waivers that are below what the SPA option would otherwise require. They are shorter in duration, and Wisconsin's offers a different eligibility category for that. Tennessee, on the other hand, in their Section 1115 waiver, they have basically adopted the SPA option package, but they have also included dental benefits in addition to the remainder of full Medicaid covered items and services. So you can see how states are both expanding beyond the SPA option or limiting the scope of the SPA option in the Section 1115 waivers that currently exist.
Have the majority of states gone with the SPA option over
Yes.
1115? Okay, thank you.
Yes.
Do any committee members have questions? Oh, maybe you could answer, excuse me, maybe you could answer a question Senator Blunt has brought up a couple of times. Senator Blunt, would you mind asking them your question you've asked the others?
Mr. Chairman, I think it may vary based on what different state Medicaid laws allow a division to do or not do. But my question has been throughout the morning. I've been concerned that this has been portrayed as a fight in the legislature, and certainly it is a fight in the legislature. But that entire fight could be avoided if the Division of Medicaid itself were to simply file a waiver request, which they could do, and extend coverage to women who under the postpartum that are not currently eligible, and retain that coverage regardless of whether the public health emergency is extended or not. I don't know if y'all want to respond to that, but we're not in session for another month, and it's everything that we've been told is that this could be done immediately today by the division itself if it was directed to do so. Thank you.
Yes, so I'll probably echo some of what you've heard earlier today. This gets to the role of the legislature, and the role of the legislature in Medicaid programs varies state by state. So some state statutes are very prescriptive about Medicaid operations, where others grant the executive branch and the agency more discretion in Medicaid program design. So your legislative counsel or staff may be in a better position to advise on the legislature's role in your state and whether or not legislative direction is required to implement these changes.
That's well said. Thank you. I think we've established that in our state, in terms of this issue, it is within the discretion of the agency and to do what they're directed to do. And if they don't, then the legislature has that option to pass a bill and hope that the governor will sign it.
Mm-hmm.
Any other questions, comments? Thank you, ladies. We certainly appreciate you taking the time to present.
Thank you very much, Chairman.
Thank you.
We're going to break for lunch. We'll return at 11:15, where we're going to have presentations on obesity and autism. Just to wrap up this morning's session, I think it went very well. I thought there's a lot of new information we heard. And as this body knows, the Senate has passed this bill out 3 times, and hopefully with the new information available, some of the House members will feel more comfortable with advancing this legislation for these ladies this next session. So anyway, we'll see you back at 1:15. Thanks. hearing today. We have two presenters today. We're going to be talking about obesity and autism. And it's kind of interesting, you know, one of the, as far as Mississippi goes, we generally rate last in terms of, or actually first in terms of hypertension and diabetes issues. And from my opinion, it's a lot of that's driven by obesity. And so our first presenter, which is Christy Davis, who's a doctor of nurse practitioner and with metabolic medicine of Mississippi, will be our first presenter. So Christy, would you like to come on down? And with Ms. Davis is Whitney Herring, Dr. Whitney Herring, and she's the medical director, pediatric obesity medicine and nutritional program with the Mississippi Center for Advanced Medicine. So ladies, go ahead.
Thank you, Senator Blackwell. We appreciate this opportunity to come and talk to you about the challenges that we're having in our clinic and what we're seeing in our practice with the obesity epidemic. Like you mentioned or started talking about, we have a lot of, sorry about that. Can you hear me now? Between myself and Dr. Herring, we have a lot of experience in obesity, pediatrics, endocrinology, diabetes, and even with all of our experience, we are struggling to take care of our patients in Mississippi. There's a lot of times where I know we are sitting in clinics in our rooms and we're just handing tissues out and saying, I'm sorry, I can't help you. Even though we have the training, we have the tools that would be available, we don't have coverage and we don't have these tools available to us. So I want to start out by talking about obesity as a chronic disease. I think a lot of times it gets framed only as a lifestyle choice. But in 2013, the American Medical Board, American Medical Association, deemed that it was a chronic disease. It met all of the criteria for a disease that needed to have treatment and prevention interventions. What we find is our patients, by the time they see us, often have faced a lot of bias and discrimination regarding their chronic disease. What occurs is they have inferior health care and they then avoid health care altogether. So these patients have about a 93% of those patients affected by obesity have unmet medical needs. So that's where we get to a point, like you mentioned, hypertension, diabetes, and we start having other chronic conditions based on not taking care of this in the beginning, not having any prevention. Across the United States, our pediatric obesity rates are about 22%, a little bit higher in Mississippi. We are first in the nation for obesity rates in high school students at 23.5%. We have higher rates in our Hispanic and our Black population. Our highest rates of obesity is in our lower and middle income groups. There are multiple risk factors for obesity. Genetics, about 70% of our body habitus, whether that be thick or thin, is based on what we inherit from our parents, whether that be genetic or that be our behavioral patterns. Even maternal weight, pre-pregnancy weight plays a factor into a person's body weight for the rest of their life. We live in an obesogenic food environment. So for example, if I have a patient that is a single mother that has 3 children and 2 jobs, it's going to be very hard for her to go home every night and cook a very healthy, nutritious meal. So we're doing the best we can to meet patients like that where they are. Of course, sedentary behavior and other issues can cause this. Medications is a big driver of obesity. We think about things like steroids or patients that may have asthma and they're on steroids so they can breathe. That's a big promoter of weight gain. Also, psychiatric medications are a big driver in weight gain sometimes. We see that the rates for anxiety and depression, especially in our pediatric population, is increasing. Those medications to treat that cause weight gain. Lack of sleep, and I put unhealthy diet all the way at the bottom because there's so many factors that go into a person's weight before we ever even think about what they've put on their fork. We know that obesity in adolescents has increased over the last 30 years by at least 15 to up to 30% in some studies. Obese adolescents risk becoming obese adults by 50 to 75%. And those adolescents that are obese grow up to be obese adults who grow up to have obese children. So we've got to be able to get in there and break that cycle somehow. We've got to be able to treat our pediatric population and our adult population. All right, so I want Dr. Herring to talk about some of her patients for just a minute.
Okay, so a big question is, can we lose weight with just lifestyle changes? And when I say lifestyle changes, I'm specifically referring to diet and exercise. So this is a patient of mine that I want to tell you about. It's a 17-year-old male who was extremely picky with his eating. I'm talking maximum five things that he would eat. He also had an elevated blood sugar. I was seeing him for about 3 years, and for those first 2 years of treatment, he continued to gain weight. We did multiple visits, saw dietitians. We even did very specific help with new food introduction, and he went up to 272 pounds. All of a sudden at 2 years, the light bulb came on and he was motivated. And so he started making those changes that we had been asking of him. He increased his physical activity. He accepted new, healthier foods. And believe it or not, over the past year, he's now at 171 pounds. So he lost 37% of his total body weight. And what means a lot to us is about 5%. If we can just get 5%, then that should be meaningful from a medical standpoint. But the usual weight loss with lifestyle changes is more like 10%. And the problem is that, yes, it's difficult in the beginning to lose that weight, but it's also hard to lose the weight because then mostly after a year or so, you start to regain that weight. So why is that? Well, you can see this sort of tug of war picture. And what happens is that our bodies really are programmed to gain weight, or they kind of have a set point. And what the set point is that our bodies have a weight that it wants us to be sitting at, okay? And what happens is when you start to make changes, you might eat healthier, you might exercise, but as you are losing weight, the body's hormones actually fight against you. So the hunger hormones go up, metabolism goes down. Those hormones that give you satisfaction, they also go down. So it really is this back and forth, and kind of explains why it's so difficult not only to lose weight in the beginning, but to maintain that. And like she said, greater than 70% of total weight is genetic or inherited. And that can be the kind of genetic obesity that runs in families. It could be something that goes wrong in the gene that then results in obesity. So I wanted to give you another example of a patient who we use medicine with. The first one we did not. This is an 18-year-old female with sleep apnea. This patient requires CPAP. So if she does not have CPAP, her oxygen levels drop extremely low at night, and this is very hard on her body, her heart, other systems. We have been seeing her for about 2 years. She had initially stabilized her weight with lifestyle changes, but then began to, increase again. So she started coming to me around the weight of 350. We started a medication to suppress her appetite, but we started a low dose. She continued to gain weight. She went up to 361 pounds. We finally got up to a maximum dose for her, and she started to lose weight. She's now down to 334 pounds. So I just wanted to give you an example of what medicine can do.
Passing the baton, thank you. And this graph here shows what the breakdown of the US population looks like obesity wise. And if you look at our Black females, 57% is quite a bit more than our 40% baseline that we have across the United States. The disparity is so great that the National Hispanic Caucus of State Legislators and the National Black Caucus of State Legislators have put forth some effort to increase states' ability to see that need to prepare for the next public health epidemic by addressing the high rates of obesity. What we saw with COVID-19 is patients that were affected by obesity were more likely to be admitted to the hospital. They were more likely to be placed on ventilator or life support, and they were more likely to die from COVID-19. And when we see a population that is disproportionately affected by that, that's where our concern comes in. They did include Medicaid in their call to action. So this is kind of where we've been and where we're going in the United States. We started out in 1960 tracking obesity. That's where I guess it started to, people notice that it was a problem, and about a 10% rate. I suspect that these are probably people that truly have genetic obesity. We see a little bit of an increase, and this is going to be y'all's fun fact of the day. So we see a little bit of increase, but when you get to the mid-1970s, that's where we start to see a big uptick. There's a theory out there that the 7-Eleven introducing the big gulp, the 32-ounce big gulp, does everybody know what I'm talking about? Before that, we had these cute little Coke bottles that were 6 ounces, that were 75 calories. That wouldn't matter if you had one of those every now and then. But now we've got 32 ounces or 350 to 400 calories with free refills. So you can see how that rate just goes straight up. We leveled off for a little while and then started uptick again. So we're up to right at a 40% rate in Mississippi now. Across the nation, that's pretty much the same.
I'm sorry. So is that big gulp theory? Is it a theory or is it fact?
I feel like it's a fact. What do you think?
Well, there's something going on from between 80 and 88 that did that. So
Seems likely.
I guess it's fact.
I feel like somebody from 7-Eleven is going to come get me
Right.
one day for repeating that, but.
So it's our culture that went to that, basically.
That's right.
Okay.
So we're looking at being up to a 50% obesity rate across the nation by the year 2030. So the scary thing is in Mississippi, our estimate is to be up to 66.7% by the year 2030. And I'll throw something even scarier out there. If we include all of our obesity rate right now, what we have in Mississippi, and we add overweight to that, we're at a 72% obese, or a 72% overweight and obesity rate. So yes, our environment has changed and we've got to change with it. We track these things. Metabolic syndrome is everything that kind of surrounds obesity, everything that goes with it, diabetes or high blood sugar, high blood pressure, high cholesterol. This is from just the Blue Cross Blue Shield State of Mississippi website. I was trying to find something that would show, you know, when we go have our healthy year, we go have our physicals, that's what we're looking at. But what are we doing with that information? We're not using it for prevention. We're just tracking it and we're watching it go up. So this is most of the facts that I'm giving you is from the Mississippi Obesity Action Plan that the State Department of Health put out in 2018, which I think is an excellent document. I don't know what we're doing with it, but it's an excellent read. Over the next 20 years, Mississippi's obesity rate is expected to contribute to over 400,000 new cases of type 2 diabetes, over 800,000 new cases of heart disease and stroke, over 100,000 cases of obesity-related cancer. So the obesity-related cancer is one thing that I really didn't realize until years ago when I started really treating obesity that was something to be concerned about. But about 40% of cancers that are diagnosed in the United States are associated with obesity. Overall, we're seeing a 13% decrease in our obesity rate. in our cancer rate, I'm sorry, but we're seeing a 7% increase in those cancers that are associated with obesity, because we're seeing that obesity rate go up. And also, I think that these patients are not offered their age-appropriate screenings. They get poor quality health care. We have research that shows that. I'm not going to go through each one of these, but there are over 200 comorbidities that are associated with obesity. Osteoarthritis, hypertension, diabetes, stroke, also anxiety, decreased work productivity, increased work absenteeism. I'm going to focus on diabetes because that's probably the one that we're most familiar with being associated with with obesity. The CDC thinks that we have about a 30% pre-diabetes rate in Mississippi, whether that's diagnosed or not. So they believe that we have 600 to 700,000 Mississippians that are on the path to developing type 2 diabetes. Diabetes is expensive to treat. So it's right at $17,000 a year to treat type 2 diabetes. But let me tell you what we see in our clinic. These patients don't just have diabetes. They have hypertension. They have high cholesterol. My adult patients probably are looking at a $30,000 knee replacement. They probably are looking at a very expensive first or second heart attack or stroke. It's never just the diabetes. We could treat all of those things at one time by treating obesity. About half of Mississippians that died in 2016 died of those leading causes, those heart disease, cancer, stroke, diabetes, hypertension, all of those associated with obesity. So we can either watch those numbers increase, or we can do something to get ahead of this with prevention, with aggressive lifestyle therapy, in addition to medication, bariatric surgery for the appropriate numbers, appropriate patients. I know that while y'all are listening to me talk, you're seeing dollar signs roll in your eyes. I want to talk about that too, the cost related to obesity. It's a 40% increase in healthcare costs when we look at a person that is affected by obesity versus not. In 2008, Mississippi spent $925 million in healthcare dollars as directly related to obesity. I know 2008 was a while back. That's the most recent data I could find. We probably don't want to know what that number is now. It's estimated that about 8% of the Medicaid budget is directly related to obesity. And Medicaid and Medicare kind of get lumped together a lot when we're looking at these studies. They pick up the brunt of this healthcare cost. So about 40% of that 69 million is associated directly with obesity. I want to talk a little bit about workforce costs. We know that as the BMI, the body mass index, goes up, the work absenteeism also goes up. For people that have a BMI over 40, on average, they miss at least 7 additional days of work per year. In work productivity loss costs, we can look at 13 to 26 billion a year annually across the nation. I bring that up because my concern is these Mississippians that are affected by obesity and have all these chronic conditions and are more likely to miss more work, it's probably going to be harder for them to find and maintain employment. I'll give a personal story. When I was 23, I was a waitress at the Outback on 55, and I was pregnant, and we didn't have insurance. So we were on Medicaid, and I'm very thankful and grateful for that assistance. And I'm very thankful that I'm off of that assistance. So I feel like we're not setting these kids up to be able to get off of this assistance. All right, I want to talk about standard of care too. I think that a lot of times people think I'm over here practicing voodoo or, something of the sort, but this is evidence-based practice that we're doing, comprehensive treatment. All of our evidence-based guidelines promote dietary changes, lifestyle modifications, progressively increasing in physical activity and exercise has the cornerstone of any type of comprehensive plan, but also pharmacotherapy and metabolic surgery when it's appropriate. I'm going to go back to this Mississippi Obesity Action Plan from the Mississippi State Department of Health that I think is so great. It actually has a goal for us to educate and encourage healthcare professionals to adopt those standards of care and to promote prevention and treatment of obesity to help our patients achieve and maintain a healthy weight. I don't know what we're doing to get to this goal, but we're not there yet. There are many options for non-surgical options for weight loss. Some are older. Some of these are FDA approved for 12 and up, and in Sivry, the rare genetics 6 and up. So we have options that would help our pediatric population. The medications that we've had in recent years that have come out have been more effective than anything that we've ever seen. When you compare it, if you compare bariatric surgery in terms of total body weight loss, not excess body weight loss like we generally do, it's pretty comparable in what we're seeing in these new medications that have safety data that go along with them. Like Whitney was saying, 5% is where we start to see major changes in health, but that's also where we start to see improvements in healthcare costs. So look at our newer medications and how effective they are. And we have some high responders that might even lose over 10 or 20%. So if we're seeing healthcare dollars go down at 5% and we're seeing health improvements even at 2.5%, imagine what 10 or 20% would do. That would be life-changing for some of these children. I tried to find something from Mississippi Medicaid to kind of see what we've done in the past. And I did find this chart. It looks like overall we're increasing our efforts on counseling, nutrition, and physical activity. And I think that's wonderful. But we're also seeing that obesity rate steadily increase. And we're also seeing, I imagine, healthcare dollars increase. So our current plan is not working. We need to add something to it. I'm going to give you one of my patient examples. This is a 48-year-old man that came to me with diabetes and high cholesterol and borderline high blood pressure. And thank God he had diabetes. And yes, Christy Davis from the Diabetes Endocrinology Clinic said, thank God my patient has diabetes because I can help him. These medications, the newer ones that we're talking about, are FDA approved under one brand has diabetes medications and another brand has weight loss medications, same medication class. So he had a BMI of 35 to start with. He could have gone for bariatric surgery, but he did not want to do that. He's been able to do several things to lose weight in the past, and he does try to exercise. He is a working professional like all of us, so he does tend to eat out more than he should, or he did. He's a dentist, so he doesn't drink sugar-sweetened beverages, which I think is the devil, in case you haven't noticed. And so he's done all he knows to do. A little backstory on him is he was diagnosed with a medical condition at age 18 and put on prednisone. That's a steroid that promotes a lot of weight gain. Somehow he was on it for 20 years. That's what we do. We put people on medication. We never take them off. That's my favorite thing to do, is take them off. By the time I got him, he was off of his prednisone, thankfully. And I'm sorry, this is a terrible graph, but this is copied and pasted directly from my electronic medical record. And what you'll see is he went from a weight of 237 pounds down to 188 pounds. And also that his blood pressure at the top is the most recent. His diastolic blood pressure improved without adding any medication. I've got his hemoglobin A1C. That's how we measure diabetes. And he started at 7.3%, not terrible. He was on metformin, but not at goal. We want him at 6.5. And we got him down to 5.2%. And then his cholesterol numbers are below that. Once again, the first column is our most recent. The last column is where he started at. Those first, under his medication list, those first two things there are just his diabetes tests and supplies. The only thing he is currently on is Ozempic, which, once again, one name brand is FDA approved for diabetes and the other FDA approved for weight loss. I couldn't have gotten him the weight loss one, unfortunately. And that's kind of where we are now. We have to wait on these kids to have diabetes before we can treat them. We can't get ahead of it with prevention. He's lost 49 pounds in about a year. So that's about a 20.7% body weight loss. That's phenomenal. If you look down a little bit further on the medications that he's not taking, because some of y'all were probably looking at those cholesterol numbers and saying, not a whole lot of difference. LDL is even a little higher, still all at goal, but he's off 2 cholesterol medications that he had been on for 20 years. He's off his acid reflux medication. And I took him off its metformin because he was having GI side effects with it, and nobody wants their dentist to have diarrhea in the middle of their root canal. So he is a very, very happy person though, with his once a week shot and almost 50-pound weight loss. I could stand up here for hours, and I won't, but hours to talk about our barriers of treatment in Mississippi, about food deserts and lack of access to dietary education. I could talk about lack of access to transport and financial issues, but the big one that stops us before we can even get there is lack of insurance coverage for the treatment options. And that's what we need y'all's help with, so we can stop sitting in those exam rooms and handing tissues out and saying, I'm sorry, I can't help you. I want to look at the potential impact of treating obesity, once again, from our very own Mississippi Obesity Action Plan. And this is from 2018. If the body mass index of Mississippi were lowered by 5%, we would save 6.9% in healthcare costs. So they equate that to being about $6.12 trillion by the year 2030, just in prevention. So we would be able to possibly prevent over 80,000 cases of type 2 diabetes, possibly prevent over 60,000 new heart attacks and strokes, possibly prevent almost 5,000 obesity-related cancers. And then the cycle that I talked about in the beginning of my slideshow with adults that are adolescents that grow into adults that have weight issues, that have children that have weight issues. If we could treat these children and along with the adults, we could see that pattern break. Just a little bit more about the potential impact of treating obesity. Once again, at 2.5%, that's where we start to see changes. 3% is where we start to see blood pressure improving. 5% is where we start to see clinically meaningful weight loss with healthcare dollars saved and also big improvements in health. But if you look down at the bottom there, about 16%, which is where we are with our anti-obesity medications, our more recent medications that have come on market, we start to see reductions in cardiovascular, heart disease. We start to see reductions in mortality, literally life-saving medication. So we have some recommendations, and this is actually from the white paper from the American Health Organization on recommendations for state policies, and that is to cover adult and pediatric weight management services, access to dietitians, anti-obesity medications, bariatric surgery. The whole report link is right there, but we've got to add something. Once again, I know y'all are seeing dollar signs just rolling your eyes, so I do want to talk about all this fear mongering about cost of these medications. Just some examples. People don't want to treat obesity. They don't. Medicare has a benefit for intensive behavioral therapy. Less than 1% of them actually use that. They also have a benefit for bariatric surgery. There are 22% smaller odds of them having surgery versus people that have commercial insurance. It's just not offered to them. There are other states that have had Medicaid come up with a plan to cover some of these services, if not all of them. And then also, I don't know how aware people are of this, but the Mississippi Board of Medical Licensure and Mississippi Board of Nursing have a lot of regulations on who can provide this service and limit that. So if over 30% of a provider's patient population or are on any type of anti-obesity, anything, any type of weight loss regimen, or if they advertise for weight loss, then they have a lot of extra things they have to do. They have to do 100 extra hours of obesity-specific CME. They have to have an application to the Board of Medical Licensure, and then they have to do 60 additional hours of obesity-specific CME or continuing medical education every 2 years to renew that. Y'all, that's a lot of stuff in addition to what we already have to do to keep our licenses current. So I think that that risk of excessive prescribing can be mitigated. Most insurances that do cover anti-obesity medication require prior authorizations. I'm in an endocrine clinic, she's in a pediatric specialty clinic. We do prior authorizations all day for everything. The way that TRICARE does it is they have to have a prior authorization to start the medication and meet criteria. And then every 4 months, we have to repeat that prior authorization to show that they are showing progress. And if they're not, and they haven't met a certain % of body weight loss, they don't get to stay on the medication. Specialists like us, if they weren't meeting progress and we couldn't change the medication or adjust the dose, we would stop it anyway. But you could put a hard stop in there on the prior authorization. You can require that only certain specialties. Blue Cross Blue Shield of Mississippi did this a while back with a expensive cholesterol medication. Only certain specialties were allowed to go through that prior authorization process. And you could do, you know, internal medicine, endocrinology, pediatrics, obesity medicine. You could even consider having a registry for pediatric obesity specialists. I can tell you it'd be a waste of your time, but you could consider doing it because nobody wants to treat obesity in pediatrics, just the specialists. That's why we're here, begging for help. One thing that I would throw out there, though, I would require that there would be some in-office comprehensive component to this. I think what we've seen in other drugs that have been overprescribed have been issues with, and there is definitely a place for telehealth and telemedicine, is that, you know, you go online, you fill out a little short questionnaire, and then you get your prescription, and that's it. That's not what we do in our clinics. And so I think having some type of stops in there for prior authorization would help. We recognize that we need more than just medication coverage. We definitely need policy changes to increase awareness about this obesity epidemic and regulate food advertising, targeting these kids. And, you know, we need to improve school environments. And there's some data out there that there would be a lot of benefit to taxing sugary drinks. But what we can do about in our clinic as specialists is we can help these patients that need it the most if we have access to the tools to help them. So just to summarize, make sure we all understand, obesity is a chronic disease. It needs to be treated. There are over 200 comorbidities and 13 different types of cancers that are associated with it. We need to have the right tools to treat the root cause of all of these different conditions. There are multiple clinical practice guidelines and recommendations to treat obesity, and we're trying, but we need y'all's help so we can treat it effectively. We've got to be able to eliminate the bias. And I think that truly is the root cause of why these things are not covered and why we don't have better efficacy in healthcare for these patients, is bias and discrimination for patients that are affected by obesity. There are definitely strategies that we can put in place to help reduce the costs or prevent, you know, opening the floodgates and overuse of that benefit, but we've got to have something. We got to start somewhere. And we also just need to really think about that overall cost of not treating it, the cost of not treating obesity and just continuing to ignore it so that we can treat downline all of these things, stroke and hypertension, diabetes. The cost of obesity is killing us as a state financially and literally, and we need y'all's help. I thank y'all for your time and attention, and we would be glad to answer any questions at all.
Thank you, Dr. Davis. I've got several questions. Did I understand, you had a slide that talked about, you know, once you're overweight, are you always going to be overweight even though, or you have that propensity to be overweight?
Well, so it is a chronic disease, and we do expect that you will always have those hormones that are fighting against you. There's some data out there that your set point may be lowered by surgery or after you've maintained your weight for a certain time. But the general answer is yes, you're always going to fight against that. When someone has cancer and we cure it, we don't say it's cured necessarily. We say it's in remission, right?
Right.
So we may be able to put the obesity in remission, but it's going to be something that we'll always have to monitor and make sure that we stay on top of.
So that sort of tug of war slide that you had kind of indicates that if you, once you do lose the weight, you're going to have to continue that lifestyle change.
Absolutely, yes.
Moving off of that, you're going to get backslide basically.
That's right. I tell my patients, there's nothing we'll be able to do here that'll be temporary. Whatever we do, this is your new lifestyle. It's got to be sustainable.
Earlier today, we had some presentations on postpartum care. And I'm just wondering, does gestational diabetes have an impact in the fetus and then the young adult, you know, moving forward?
Absolutely. And you know, on the young adult and the mother, we know those that are affected by gestational diabetes are more likely to have type 2 diabetes later in life. And if all of there's a really long answer here, but the answer is yes. There's a lot of complications that fetus will, if they don't have a miscarriage or they, you know, don't have any issues. Probably they'll be large for gestational size, 9, 10, 12 pounds. And that causes a lot of compression on the placenta and issues in itself. And it just snowballs before the baby's even born.
You mentioned there was a lack of insurance coverage. Is that globally all payers or?
No, there's definitely some pockets of insurance coverage. Generally about 30% commercial, I think, coverage. It's getting better. Larger companies cover. I think Tennessee Medicaid possibly, and some of the other states have coverage. It's becoming more common for it to be covered. I'm hoping that we won't be last.
And how do we do from a Medicaid standpoint with coverage?
Oh, nothing.
Well, for services, clinic services, it's good, but medication, nothing. No coverage.
So I'm sorry, you said for clinic visits?
Yes.
It's
So
covered?
paying for the visit to come and see me, yes, covered. Dietitian services, it depends on whether it's fee for service or managed care. It seems to be different. For medication coverage, it's 0.
Is there a reason for that?
For the medication or the debt?
Right, for the Medicaid, for not?
Well, it's the anti-obesity medication is not on the formulary currently. And so it's all self-pay.
Someone mentioned that no one wants to treat adolescent obesity, and why is that?
It's very difficult.
Obviously, if you're Medicaid, you're not getting paid, but other than that.
Well, I think that it's for several reasons. They're in pediatrics, just like really any other medical office, it's very, very busy and you're focused on wellness care. And it is in some ways a focus in terms of encouraging and addressing lifestyle issues, diet and exercise issues, but it falls to the bottom in terms of in-depth care. And so it really takes a lot of time and effort to treat obesity, and it has to be frequent visits and accountability partners and looking at all of the things, labs, other services that are needed. So in terms of medication, I would say pediatricians in general are not comfortable at all. And I understand that, but I think, you know, kind of like Christy said, it gives us a better way to help them in our clinics. And if we were to be covered for medication, you know, we are specialists, we are comfortable with this, and we're the best place to treat them. Because of that discomfort, those pediatricians in the state are not going to be trying to prescribe these medicines because they're not comfortable with them to begin with.
Are you aware of other states, Medicaid programs cover medications for obesity?
I believe Tennessee. And
Right. Would it be possible for you to get us some documentation on that? Right. And then I think my last question is, you mentioned the medical licensure board. Seems like they may be creating hurdles. Could you expand on that a little bit? What you mentioned the role of the medical licensure board, and apparently you have to go through a lot of additional training and
Lots of hoops to jump through. So in my clinic as a nurse practitioner, I do all of the obesity management in my clinic. And my collaborating physician, Dr. East, Honey East, is licensed under the Board of Medical Licensure. And because we advertise, there's a sign on the front door, and we do weight management, she had to do 100 hours of obesity education separate from what she has to do for her other certifications. So for internal medicine, for example, I think it's 40 hours. So every 2 years, she does her 40 hours, and then she has to do 60 hours. And I do the same just because I feel like it should be the same. So it's extra hoops to jump through, and I'll just say it a little more plainly than Dr. Herring did. We're not making any money off of this. It'd be a lot more, from a business standpoint, it'd be a lot more lucrative if I was not doing obesity, if I was not spending that additional time and staff tying them up, doing prior authorizations and educating patients. And it's a lot of hoops. It's a lot of things to go through. And in primary care, they've got a lot of other issues that they need to deal with. They're putting the fires out. We're wanting to do some prevention.
Are you aware that if other states have to have the same type of continued education?
So that varies widely. Some do and some do not.
Do any committee members have questions? Yes, sir. Senator Polk.
Thank you, Mr. Chairman. I'd like to go back to one of your slides about the cost. If we could save, I believe it was 5% on the weight factor, we could save 6.2 maybe trillion dollars in 8 years.
That was from 2018, so it's a little behind, but I wanted to use this because this is from the Mississippi State Department of Health. This is our data.
Could you show me that slide?
Right here, sir.
Oh, okay, 5%, 6 trillion by 2030. Trillion, not billion,
Yes, sir.
in Mississippi only.
Yes, sir.
I didn't know we spent that much on medical anything.
Well, if you add it up over, I guess in 2018, it would have been 12 years, and probably the data is, I imagine, a little older than that by the time you get to writing it up. So let's say over 15 years, and you start thinking of those over 200 comorbidities, maybe they're expecting it to add up. But this is what the Mississippi State Department of Health says.
Okay, thank you.
Any other questions from committee members? Thank you, ladies. Appreciate it.
Thank you.
Next up, we have Christy Spites, who's chair of the Mississippi Autism Advisory Committee. And I think you got several folks with you, Danelle Roberts, Dr. Roberts, who's with Wills Way, LLC, Pediatric Behavioral Psychology. And you have a Mrs. Shanika Nguyen, who's a patient representative, I think. And you can proceed when you're ready.
Okay, thank you. Good afternoon. Thank you, Chairman Blackwell and committee members for allowing us this opportunity to come and speak with you today. Want to introduce myself. As he said, I am Christy Spites. Governor Reeves appointed me to serve on the Mississippi Autism Advisory Committee in September of 2021. In November, I was elected as the chairperson to represent, and on the committee, I represent being a parent of an autistic child, as well as being a small business owner who employs autistic teens and adults. My business is Spectrum SIP. It's located on North Jefferson Street in Bellhaven. My journey with autism began. I'm gonna try to figure out what I need to do. Slide up there. Sorry. Got it. Oops. I love it when I'll do it smaller than we are. Okay, there we go. Okay. My journey with being an autism advocate started in 2014 when our second child, Buckley, was diagnosed. He was being seen for dyslexia and kind of tripped into the autism diagnosis. It was quite a shock for us. So he was 12 at the time, and in 2014, insurance, there was no coverage for autism therapy at that time. So we have paid out of pocket for everything he's received. All therapy, speech therapy, occupational therapy, autism therapy. So it's been quite a process. The cost is significant. My husband started a medical consulting business to supplement the income to pay for all of Buckley's therapy, and he's a physician. So if that tells you anything, costs add up. He attended New Summit School for 2 years, and that didn't work out. That was good while it was good, but he was bullied during that time just because by another autistic student. And so we pulled him out and homeschooled him. When he went into puberty, things got worse. As we all know, puberty is awful anyway. And then you add that to an autistic child who has emotional regulation issues, executive functioning issues, social pragmatic issues, and it just becomes a whole storm. So I started homeschooling him, and that just did not go well for us. So we sought out Ann Thompson, who is a Christian counselor in Memphis, Tennessee. She was recommended by another friend of ours who has a child with special needs and troubled individuals. So we drove over to Memphis, and before we made it back to Jackson, she found wilderness therapy in Aspiro in Utah, the Vantage Point, and it's for autistic individuals. He spent 64 days there. Then he transitioned back home for 1 month. And then we sent him to Black Mountain Academy for boys in North Carolina, which is a school specifically for autistic children, well, young men. He stayed there for 14 months, was able to catch up, covered 2 years of school during that time, received therapy every day. Social pragmatics and executive functioning teaching. He was responsible for washing his clothes, planning meals. He had a job while he was there. So it was just unbelievably beneficial to him. He returned home, he transitioned back home, and in order to transition, the parents have to comply with everything that was set forth at the school, because we all backslide, we all get comfortable, we revert back to old ways of parenting that can cause problems and aren't necessarily best for our children. So he came home, he went to the education center for his junior year and senior year. He was the valedictorian, star student, unbelievable grades, did well. Worked at Spectrum SIP. I opened that specifically to employ him, actually, because I was really concerned that he would not be able to get a job here in Mississippi just because there's not a whole lot of information about autism. A lot of people have skewed views of what that actually means or what it is, what it looks like. So that's why I opened Spectrum SIP, for him to have a job. It's obviously grown past that, but he attended 1 year of college, decided that was not for him. Over the summer, he worked with an electrician, And now he is currently employed as a termite technician for Terminex and is doing very well. So that's what's brought us to this point, or me to this point of advocating for our autistic community. Since we're talking about autism, I want to tell you, and this is a very wordy slide, and I apologize, but I want you to make sure and understand what autism is, because I have had people ask me, well, how did he get it? You know, was it a vaccine? When did he start it? And the answer is simple. Okay, autism is a developmental disability caused by differences in the brain. It is characterized by impairments in social interactions, communication, repetitive stereotypical behaviors, interests, and activities. Onset is usually before the age of 3 years old, although most children are not diagnosed that early. The severity of impairment varies from person to person. Not any two people are alike. As typical neurotypical people, the same goes to say for autistic people. I know we have television shows that portray autistic individuals such as The Good Doctor, and only about 3% of autistic individuals are savants, which The Good Doctor portrays a savant. The show Atypical, that portrays another view of what autism looks like. And then Rain Man, of course, that's what I thought when I was told Buckley was autistic. I'm like, no, he's not Rain Man. So anyway, it can also, social interactions can be very difficult for them, maintaining interactions, impaired ability to recognize, experience socially acceptable emotions, difficulty processing and appreciating the thoughts and feelings of others. Communication deficits range from completely verbal, very sophisticated vocabulary to no verbal ability at all, but they are able to communicate in other ways. Intelligence is usually not an issue. There are several comorbidities that can go along with autism though. Autistic people can also display repetitive and stereotypical rigid thought behaviors. They can stim. I don't know if sometimes you've seen children or young teens clapping or flapping or, rocking or maybe making a certain noise. That got Buckley in trouble a lot. He was a noisemaker when he was nervous. He would tap on things and he would make noise that, just kind of very annoying things for a classroom and very disruptive. But that was his way. It's called stimming, and that is their way of actually self-soothing. A lot of people try to get them to stop doing that, but if they can find another way to stim that's not so disruptive, it usually helps center them back down and calm down. People on the spectrum behave, communicate, interact, and learn in ways that are different from you and I. There's often nothing about how they look that sets them apart. My son Buckley gets asked all the time, is like, well, you don't look autistic. And he's like, well, what does an autistic person look like? They look like me. They look like you. There is no physical tell of what they look like. And some may have, like I said, very advanced conversational skills, and some need a lot of help with their daily lives to the point of they're still not potty trained, and diapers, need to be help being fed because of textural issues, to pretty independent. And I consider my son very independent. He's now 20 years old. He does still live at home, and he probably will for a while because emotionally, he's younger. I would say he's probably 15, younger, maybe younger than that, because he still plays with toys. But you know what? That helps him regulate and keep calm. He comes home every day from work and he pours out his toys in his room and he plays with his little action figures. But he's not drinking and doing drugs. So that's a good thing. So we're okay with the toy playing. But other than that, he knows how to wash his clothes. He knows how to cook his meals. He drives. He's actually going to be getting a company vehicle after his 45-day probation period on the job. So we're excited about that. So he's very independent, takes care of his own health care, sees a therapist, sets up his appointments. We still have to help him shop because he does not enjoy doing that. Hey, Russell. So that's what autism is. That's what it looks like. It can look like a lot of different things. It's called a spectrum for a reason. The spectrum is not linear, it's circular, because you can have comorbidities all over the map. And Dr. Roberts can explain more about that if need be. The next thing I wanted to talk about real quickly is what is the Mississippi Autism Advisory Committee. And I'm adding this on here because I've met with a few legislators and they did not know about us. So I want to let you know. In 2011, during the regular session, the House Bill 1125 created the Mississippi Autism Advisory Committee because the legislators recognized the urgent need for strategies on how to best identify, treat, educate, accommodate, and employ people with autism spectrum disorder and assist the family members. We are tasked with the mission to study, make recommendations, and develop a strategic plan yearly to educate and train students with autism to maximize their productivity within the workforce. Each year we present an annual plan. It's due July 1st. I don't know who, there's no oversight to who we present it to, but we turn it in and it's sent to all of you. You probably received it in an email. I have made these booklets that we have for you to look at as well. Just instead of on a computer, sometimes it's nice to hold a booklet in your hand. But we're tasked with a recommendation to help autistic individuals and their families. So we meet 6 times a year, and based on our meetings and findings and research, we voted unanimously for the recommendation to increase Medicaid reimbursement rates specific to the CPT codes 97153, 97155, 97156, with competitive rates to incentivize more providers to accept Medicaid, and also to have professional retention of our state's certified BCAs and RBTs. Those are registered behavioral technicians and board certified behavioral analysis. These specific codes are the most used codes for autism therapy per the providers who responded to our seeking them out and asking them. So that is where we are. That is what our recommendation is. And I'm going to turn it over to Dr. Roberts so she can go through and she, like he said, she owns, co-owner of Will's Way. She, it's a private psychology and ABA practice with clinics in Hattiesburg, Gulfport, McGee, and Summit. She earned her doctorate from University of Southern Mississippi in 2005. She's a licensed psychologist, a licensed behavioral analyst. She's a past member of Mississippi Autism Advisory Committee, past president of the Behavioral Analysis Association of Mississippi, and a past communications officer for the Mississippi Psychological Association. She's currently a member of the Council of Autism Service Providers.
Thank you so much for having us today. I was asked to come today, just talk a little more about the specific codes and the rates because I am a provider, so I understand the need for that in the state. This is some data that the MAC has put together for the Mississippi Medicaid, specifically the reimbursement rates for those codes in comparison to neighboring states. What's on this slide is Mississippi, then then Arkansas, Alabama, Louisiana, and Georgia. I do believe, so this is, I'm a behavior analyst, so I speak in data and I like graphs. So this is the same information that's presented on this chart. I just find it a little, easier to visually look at from afar. Mississippi is the first column in each of those groupings. So the first grouping here is one of the codes, the 97153. That's our direct therapy. That's the most widely used code. That is the one-on-one therapy for those children with autism. The national recommendation is for children on the autism spectrum to get up to 40 hours a week of therapy. So it's school, essentially. It's a full-time, 8 to 5. There are centers all over the United States and the world who provide 40 hours a week of therapy to children on the autism spectrum. To my knowledge, there's not a center in Mississippi that regularly provides 40 hours. My particular clinics provide a maximum of 20 hours a week, and we have anywhere from 8 hours up to 20 hours. We have some children who come an hour a week for social skills therapy. We have some children who come 20 hours a week. Other clinics have different schedules and they may offer more. In general, this is the same mentality you would think of when you think of early intervention or school. Coming once a week, every now and then is not going to make a significant difference. So this is a intensive, repetitive type of therapy in which we are attempting to teach skills that are significantly lacking in young children. So language skills, communication skills, social skills. So looking at this direct therapy, this is the majority of what is used and billed, and Mississippi is the lowest on this particular scale. One number that's on this chart that is not on the table is the second line is TRICARE. And I felt, TRICARE is a not a commercial insurance, it's a government insurance as well for obviously military families all over the world. And so this is the first two columns, the royal blue and the orange compare Mississippi Medicaid rates to TRICARE rates. The second column is Arkansas's rates. The fourth is Alabama, Louisiana's purple, Georgia's green, and Florida is the dark blue. So just kind of give you an idea of what our neighboring states and what other government regulated, insurance covers. The second group of bars are what we call treatment modification. And that is what's used to be called, we called it supervision. But in the world of applied behavior analysis, it's a tiered system, similar to a medical facility where you've got physicians, nurses, RN, LPN, CNAs, that tiered model of care. In ABA, it's a similar model. So you have board certified behavior analyst, which is licensed by the Mississippi Autism Board. And underneath that, you can have assistant behavior analyst, or you can have registered behavior technician. Your registered behavior technicians typically function in doing this work, and either your assistants or your behavior analysts bill the codes on the next two. And so that's kind of what you would see. Your professional staff are billing the second two groups of either treatment modification or parent training. So treatment modification is making sure that the quality of care is being done, that the goals are being made, that the specific goals that we're working on are appropriate for the individual. The RBTs are an entry-level position. Minimal education is needed compared to the professional staff. So, in essence, Mississippi is, the lowest on the comparison when it comes to direct therapy. They're not the lowest when it comes to treatment modification. It's relative, it's higher than Alabama and Florida based on the numbers that we have. And then it's lower on that. I also have, one of the things she mentioned I was a part of is called the Council of Autism Service Providers, but it's a national nonprofit of autism service providers. And this is and I'll be happy to share this. This is many other states of this is all Medicaid rates, and it's everywhere from Vermont, Michigan, Nebraska, Montana. It's all that had been reported. And Mississippi falls, kind of in the middle on most of those. So we're not the lowest, but we're not the highest. As a provider, I think it's important that I state this, that, it's such a complicated issue because it's not just about how much money that we get, but it's also, there are so few Medicaid providers. I'm not a Medicaid provider. I don't know many people in the state of Mississippi in private practice in mental health who are, regardless if we're talking about psychology or ABA. The centers who do take Medicaid are nonprofits. They can apply for grants. They can do fundraisers. They can supplement that. As a private practice person, my concerns are with the actual dollar amount that we get per hour, what that in turn allows me to pay somebody to do the job. And we are competing with inflation all around. All of our costs have gone up like everybody else's, but medical reimbursement does not change. We don't get paid more from TRICARE or Blue Cross or anyone else just because of that. So what we find is that our professionals that are graduating from University of Mississippi, from Mississippi State, they're just leaving. They're going to Florida, they're going to Louisiana, they're making $100 grand when they're making 50 or 60 here, because the reimbursement rates and what they're able to, to recoup in those areas are more. So we struggle to keep professionals. We struggle to train those professionals. And then within that also, I have lots of questions about just Medicaid in general. To me, Medicaid is like Goliath, and I feel like David as a small provider. And I think most independent practitioners feel the same way. And I know you can't fix that, but one of the things I would say to your committee is that I wish Medicaid were more transparent about what the rules are, the recommendations, the policies. So not only are you looking at the individual amount that we have to accept per hour of therapy, for that, but how does that impact our private payers? If a family's got a $3,000 deductible, and in January, they've got Blue Cross primary, Medicaid secondary, and they've got a $3,000 deductible, what happens to those of us who are filing for that? Do we get paid from that? We can't charge the families for the out-of-pocket, what Blue Cross says the patient's responsible for. If I'm in network with Medicaid, I'm taking a lower rate and I'm losing all of that revenue that I would be getting from that primary payer. And just as in full disclosure, I called Medicaid a couple of months ago because I recognize that this is such a need. And I get so tired of when a family calls, the very first thing they say is, you take Medicaid. And I say, no, I'm sorry, we don't. And I'm kind of tired of saying that. For 15 years, I've been telling people no. And so I reached out, and I'm trying to, this is part of why I'm here. I've talked to other professionals. I reached out to CAS to try to get some help, but I didn't get, nobody helps you with that. You can't get anybody on the phone to tell you as a provider, here's what we expect. Here are the policies. Here's the reimbursement schedule. Here is what the authorization process looks like. Here's what you should expect in an audit, because, we get audited from TRICARE fairly a good amount. But TRICARE also has a manual about this thick of all the things I have to do. And it's a line by line. We expect these things, and every note, these things are very clearly laid out. And I don't find that with Medicaid. So I think as a private practitioner, myself, and this is a very small community of providers right now in Mississippi. I can probably name almost all of the providers by name if you wanted me to. We all feel that it's just the unknown. There's a lot of unknown about what Medicaid would require, what that authorization process looks like, how would we handle the primary and secondary filing and all of that, and we just don't know. So I am here to ask really kind of for two things. One is an increase in the rates, as Chrissy was mentioning, and then two, to really be transparent with the policies and to find some entity within Medicaid to help those of us out in the community who very well would become a Medicaid provider if we felt comfortable taking that on. We're not, all the other insurances that I have, even TRICARE, and I keep saying that if you're not familiar with TRICARE, it is a mammoth system, and it's one of the most complicated and aggravating insurances that I deal with. But I can pick up the phone and have a human being on the phone talking to me about claims, reimbursement, authorizations. There are people that I can speak to, provider relations, right? Blue Cross has that, United Healthcare has that, Cigna has that. I haven't been able to find that person in Medicaid. When I called and asked questions, she said, you just need to fill out the application. And I said, okay, thanks, have a great day. And I did not fill out the application. And so I would encourage you guys to also think about that and encourage the powers that be in Medicaid to help those of us to do this. I tried to do like a number. I went to school for psychology, not accounting and not a business, but trying to figure out how to tell you how much it costs. I mean, obviously it varies based on overhead and how much, et cetera, et cetera. Our newest clinic is in McGee. It's very small. Right now we have one person on maternity leave, so we have one therapist there. It's 1,400 square feet. But just that, rent, utilities, power, liability insurance, I could go on, right? The list of expenses for that little building is this much. We personally are probably on the lower end of what we pay our staff. We have people in the area who are now offering RBTs with a high school diploma over $20 an hour to do this therapy. So I would like to be able to be more competitive with those providers. We have a hard time keeping staff when they can, go somewhere and make $22 an hour with a high school diploma, which is great, fantastic, but I have to be able to maintain that. But this is a difficult thing to tell. So, obviously if I have a nice fancy building or, I spend a lot of money, that number could change, but this is bare bones minimum of what it takes to pay for the providers, the rent, the insurance, the internet, the electronic health records, all those expenses divided by 12. Just to kind of give you an idea, this is, some salary data of the professionals that we're talking about. The average for an RBT is $38,000. That's $18 an hour. And the average for the professional level is about $75,000. So that, This is not, we're not millionaires doing this by any means, but just kind of give you an idea of why and where I came up with that goal there. That's where that number came from. Do you want to go back over this, or I talk for a living, that's what I do. So part of this is that we are making an appeal to you guys, to the committee, to increase the reimbursement rates to a comparable level so that we can pay our staff to keep the staff, because they're just leaving. That's just what's happening. I have to make phone calls weekly to tell parents, I'm sorry, I have to cancel your kids' therapy today. I don't have a therapist because they quit today. And now they're working for Clinic B over here, making more money. And that's very difficult to do. But so this is looking at Medicaid pays providers 72% of what Medicare pays for similar services. Autism does not have a specific Medicare equivalent. I actually have a client we see pediatrics mainly in our clinic, but I have one client who, he still comes, he's 22. He's been coming to see me since he was 13. He comes an hour a week. We're kind of his social group. He's now in Medicare. So he actually had private Blue Cross until he became an adult and he went to Medicare, and he can no longer come to us. Like, we take a sliding fee for him, and his parents just self-pay for him to come because he has Medicare. And so Medicare doesn't cover either. So one of the things that as a provider is confusing too about is what Medicaid allows, the percentage of treatment modification, planning, supervision that's required. Because these are entry-level positions with 40 hours of coursework, that's all they have to provide this therapy. It is absolutely essential that there's some oversight. It would be essential to letting a CNA provide all the care in a hospital setting. Like trust them to do that, right? You wouldn't do that, and you wouldn't let teacher assistants do that without supervision in a classroom. It's the same type of thing. We need that oversight, and so there has to be specific authorization for that. So our licensure requires a percentage of RBTs. It's 5% of the work has to be, you have to lay eyes on, and then you have to provide, 5 to 10, up to 20%, depending on the insurance, percentage of the hours of supervision for that individual child. And so looking at what the rules are from Medicaid as to how often this can occur as a percentage of the direct therapy. If a child comes 20 hours a week, they need more supervision than if a child comes 1 hour a week, right? And then another thing Mississippi Medicaid is not currently doing is not differentiating reimbursement between who's providing the service. So the reality is that I come to work today, this RBT has the flu, or they have COVID, or they quit with no notice. I have two choices. I can send the supervisor, the BCBA, in to see that client, or I can cancel that client, right? So when at all possible, we will send the professional in to see the person to keep that client in therapy because it's a medically necessary treatment. There's no difference in what we're getting reimbursed. So you have someone with a high school diploma and someone with a master's degree getting reimbursed the same amount of money for that same amount of time. Obviously, they make different money. That's just not feasible to do. So we would ask also that it be that there be a scale based on the education and certificate or certification that someone has. So BCBA, BCADA, that's that assistant. There's a lot of acronyms. This is the whole world we live in, and that registered behavior technician. But you just kind of think of it as that, the professional, the mid-level, and the entry-level position. Our licensure requires certain provisions. The initial Medicaid bill or reimbursement rates did not allow for even what was sufficient to meet our ethical requirements, meaning we're going to have to provide the service because we're ethically and our license is dependent on us providing that service, but we are not going to get paid for that service at all. Which obviously, once again, if as a private business with no other means except for reimbursement, there's only so much you can take that on or so long you can do that. I can't supplement with grants or with fundraising or other types of donations. These are the three service providers in the state. I mean, you did all these. I don't know. I'm winging this.
This chart depicts the when she mentioned there, she could name off the providers who do take Medicaid. I can name them off for you. There's only 6. Well, there's now another one, but that just happened recently, and it's the K Clinic. They now have 4 Medicaid clients. But there's 6 providers in the state. There's the Autism Center of North Mississippi, that's in Tupelo. There's the Golden Triangle Autism Center, that's in West Point. Mississippi Behavioral Services, that's in Jackson. Gulf Coast Education Solutions is in Gulfport. Mississippi Center for Autism Related Disabilities, or MCARD, is located in D'Iberville, and Canopy Autism Solutions in Jackson. So these are the 3, the Canopy, Autism, MCARD, and Autism of North Mississippi. Those are the 3 that are nonprofits also, so they can supplement their incomes. They can take Medicaid. But even though they do take Medicaid, the numbers are low, how many they have, how many they're currently treating. Canopy only has 25. MCARD 48, Autism Center 85. But then this is where it gets really interesting. The wait list. You have 84 children on the wait list, 344 children on the wait list, 97 children on the wait list. And the majority of those are Medicaid people. There's Medicaid children. The other problem is, like she said, they're losing staffing. Autism of North Mississippi on June 30th, they are dismissing 26 clients and discontinuing services to clients who are 10 years or older. I mean, that's right before puberty. That's when the thing gets real. That's when things get crazy. I mean, I don't know where I would be or where my son would be if we didn't have access to care. And like I said, we paid out of pocket, so we didn't have to worry about the limitations of insurance putting on us by how many hours he could have, or how many hours they would only reimburse for, or if he could even get into therapy, or if there was a provider available, we could pay for it. So I can't imagine what those families do. We've never gone without therapy, and I can't imagine waiting 1 week, much less a year or more. And the cost adds up for that. Okay, so now the prevalence of autism diagnosis is 1 in 44 children. All right, that's the national prevalence rate. So factoring in Mississippi's population, that gives us about 11,000 children who will need autism services in a year. So 53% of those people are going to be Medicaid recipients. So our state is clearly not meeting the need, and we're losing an entire generation, as Linda Balfour said. We are losing a generation of productive citizens because they can't get therapy that they need. The Mississippi Code, annotated 83926 in 2015, requires a health insurance policy to provide coverage for screening, diagnosis, and treatment of autism spectrum disorder. Treatment includes, but is not limited to, behavioral health treatment, pharmacy care, psychiatric, psychological, and therapeutic care, licensed speech therapists as well. The Early Medicaid Act, the Federal Medicaid Act mandates that all states provide early periodic screening, diagnosis, and treatment. That's another acronym, that's EPSDT. This mandate requires that states provide all coverable medical assistance to correct or ameliorate deficits and physical and mental illnesses and conditions in those children, even if the care is not currently in the state's Medicaid plan. So the purpose of the program is to ensure that conditions are treated early and children enter adulthood as healthy and functional adults. If left untreated, the cost can end up being $3.2 million. And yes, it's, we have a saying in our family, work hard now, play later. And that's kind of where this falls in. Early intervention matters because in the long run, you could have another Buckley. You can have an adult who is independent, who is a tax-paying citizen, rather than an adult who did not have therapy and can't function, can't have a job, can't drive, and is living off their parents or governmental assistance. And that's what we see a lot of because they're not getting the care. Like I said, there's only 6 Medicaid providers in the state. The Delta has nothing. The lady who's going to join us on Zoom in just a moment, she's from McGee and she's on Medicaid and she's trying to get her child some therapy. So that's one of the reasons why we're pushing for this. This was a report submitted. I had a request of information from the Office of the Medicaid, and this is what they sent. regarding the amount of the dollars for the specified codes we've been speaking about of what was spent in fiscal year 21 and this year. And once again, one thing that stands out to me is the number of beneficiaries, very low. So there's not many people receiving the funds. Next is the allowable amounts. This is commercial versus the maximum allowable rates, commercial, and then Medicaid rates, and what we're asking for. What we're asking for is the maximum allowable, or at the very least, comparable to commercial. Because as she said, what it would take to incentivize providers, because she doesn't currently provide for Medicaid. If we had more Medicaid providers in these smaller clinics, that would cut down the bulk of these big wait lists that people are having to travel to all over the state. So that's what we're asking for, is for you to consider that. And the other side of that too, like she said, is the limitations that Medicaid currently has, the transparency, dealing with the allowable hours, and what else? Yeah, there's some codes, the 97153, the maximum allowable hours is 32 units. And that's only 8 hours. And she said, what was that? 40 hours, that can be 40 hours, because Buckley had boarding school, that was therapeutic, that would be about right. So anyway, that going forward. Yeah. So that's the very significant difference. Okay, is Miss Nguyen, is she on Zoom? Miss Nguyen, can you hear us?
Can you hear me?
Yes, ma'am.
Okay, I'm here.
Okay, Miss Nguyen is from McGee, Mississippi. She's the mother of 2 children, Lyndon and Austin, and she's going to provide information to the committee about being a parent as a Medicaid recipient and navigating therapy for her son. Ms. Nguyen, go ahead.
Thank you for allowing me to be able to speak with you all today. As Ms. Christie said, and along with Ms. Space, I am Shanika Nguyen. I do have a son, Austin, who is 5 years old. He is on the spectrum. Austin, actually, he does attend school. He actually attends a school in Mendenhall, Mississippi, which is for a developmentally delayed. This is his 3rd year, and it's kind of like a preschool. He would be in kindergarten this year had I chose to go ahead and let Austin go there. But as a parent, I was a little afraid because I didn't feel he was quite ready to move along. When your kid is on the spectrum or has autism, they do face a lot of difficulties, and the ladies have done a great job of telling you a lot of those things. My son Austin has a lot of the behavior issues that go along with autism, which leads me to wanting to get him the ABA, which I know would really, I think would really help him. He does receive some services at school. He receives PT, which is physical therapy, the OT, occupational and speech, which do aid in helping him, and which I know has really helped him to be able to prosper and grow. He loves school. It really helps him, but he needs these extra services. And yesterday, I actually got a call. He was attending an OT outside of what he gets at school, and it's performance therapy. And I got him recently here where he was taking OT. I got a call yesterday. Okay, he's only started, like, I think maybe he's been with them probably going on maybe a month, only to hear you're not going to be able to continue services, that the OT, the pediatric OT, has moved to Alabama. And of course, she, like you said, got more money. So now we're stuck with, okay, no OT. So that right there was a damper on my spirits, because I'm like, wow, we just got here, just kind of getting our feet wet. And now we have to try to see about Austin, getting him some more therapy. I don't know from where it's different places that we could go, but it is farther out. With us being on Medicaid, sometimes that does play a kind of set us back because a lot of clinics have waiting lists, which are long. They touched on some of the clinics that have waiting lists for Medicaid. One which I was trying to get Austin on for ABA was Canopy, but after talking to someone there, it could be he could never possibly get on there because they have kids who have aged out. Like if they're 9 or 10, they have been on the waiting list who haven't even ever been treated. So if Austin was to possibly get a spot on there, he has a waiting list of kids that are, who knows how long the waiting list is. I heard her say maybe like 84 kids. So it's long. So he may not get a chance to get that services, but I am thankful for Will's Way, which I see now Dr. Roberts has an office here.
Miss Nguyen, we lost your sound.
Are you still able to hear me now?
Okay, yes, ma'am.
Okay, I'm sorry. Okay, what I was saying with Dr. Roberts' clinic on Will's Way, which she has opened here in McGee, and I do reside here in McGee, which would be great for Austin. So when I say, oh, wow, yes, Austin will be able to now finally attend ABA therapy here in McGee. You know, hear Dr. Roberts say, hey, you're one of the ones I'm having to turn around because you do have Medicaid. So I'm like, wow, where do we go now? Because that would be great because most clinics, believe it or not, that offer a lot of these services are either in Jackson, Hattiesburg, the coast, which you explained, and just some parts of northern Mississippi. So with me being a working mother or two, I sometimes may have to take off and drive to get him to most of the services, which I don't mind. I do what I have to do for my son because I am an advocate. Not only am I just an advocate for Austin here, just as a parent, I do this at work. I am a family advocate for 5 County Child Development Head Start program.
Okay. Ms. Nguyen, are you there?
Okay, can you hear me?
Yes, ma'am.
Okay, as I was saying, I am an advocate, not just for Austin being his mom. I am an advocate for here for my job where I'm a family advocate for 5 County Child Development, which is a Head Start agency. So I am always trying to serve and get families information and resources on ways to not just help their kids, but to help others out, because we do actually here. We do serve a lot of kids that are that do have disabilities. They actually get first deals, but to be actually honest with you all, we don't have the resources here or the staff that are really able to treat these kids. So, it kind of feels a little disheartening when you're kind of promoting, hey, we want these kids that have disabilities, but in actuality, we do not really have the resources or the staff to just really be able to serve these kids. And which is a reason why with me working here, I knew that I didn't want Austin to come because I knew he wouldn't fully get all of the resources. So I chose to put him in a private, not private, but public school sector where he goes, that he's to receive those services like the OT, the PT, and the speech. He was at a facility where he kind of outgrew, and I feel he wasn't being challenged enough and getting it. So I'm in the process of now, along with now he's lost the OT at the clinic where he's previously at, trying to get him into another possibly private speech where he can continue to get speech services. And hopefully I can get him to ABA, but I know with Dr. Roberts' clinic, you do have to have private insurance. And that leads me to now trying to get him a private plan so he can be able to come to Dr. Roberts' clinic at Will's Way. So I hope that I can come up with something that will be able to get him there. But I mean, as being a working single mom, just to add him to a plan here at my job would be, I mean, it's really expensive, and with inflation going up and autistic kids kind of have a lot going on. Sometimes they have to require, like my son, he has a lot of sensory issues. He doesn't like to wear a jacket. He doesn't like to wear socks. He didn't want to wear underwear until maybe.
Yeah.
I'm sorry, seems to be going in and out.
Currently, you currently am not, your son is not in therapy, and you're trying to get private insurance because no one near you takes Medicaid, correct?
You're exactly right. Exactly what I'm trying to do, and I hope that we can get him these services because he needs these things, like I said, for the sensory and all the things that he faces. I know that ABA will help for his behavior when he has a lot of tantrums or meltdown. You know, when things change or things can't be his way, or just, you know, noise, certain things, all of these things that ABA I know will help him to be able to, you know, thrive and foster and be able to get a chance to be able to be, you know, have a chance at life, because I won't stop fighting for Austin. And I do get emotional about this because it really is, he's dear to my heart. He's my son. I care about him. I want him to have a chance to be able to thrive and get things that he needs to one day be able to take care of himself. And I'm going to always be an advocate. I always fight for him, but I want him to have that chance to do that. So I will do what I have to do.
Okay. As you can see, Miss Wynn is one of thousands of families who. Thank you, Miss Wynn.
To, you know, thrive. So thank
you so much. Like I said, she's one of thousands of families who are struggling with care for their child. And, you know, I've seen what therapy can do because my son is living proof, and every child deserves that opportunity. Like Linda said, this is a whole generation we could lose from this. And there are children who are salvageable with the right therapy, early intervention, timely therapy. They too can become productive citizens, tax-paying citizens, and giving back rather than becoming a drain on the state. And that's just the way it is. So that's it. That's our recommendation. Thank you for allowing us this time. Do y'all have any questions?
Thank you, Christy. We appreciate it. Mrs. Wynn, if you're still on, we certainly wish you and Alston well. And from the legislative standpoint, we'll certainly try to do our best to improve our coverage.
Thank you.
Kind of ironically, with the announcement of this hearing, yesterday I received a letter from the Department of Medicaid indicating that they have applied to update the reimbursement for autism spectrum disorder services to the lesser of the usual and customary charge, or a rate calculated by an actuarial firm effective the 1st of January 2023. I don't know what those rates are yet. I've asked for a copy of those, but I think the department has some concerns, and they're stepping up to the plate. We'll certainly see what we can do. And if I understand correctly, part of the backlog has to do with our reimbursement rates being so low.
Absolutely. And we being Linda and Christy Heron, you know, us three met with Drew Snyder back in March and sat down with him, and he admitted that the rates were too low, and very good feedback. We felt really good coming out of the meeting, but we had not heard anything back from him since.
Well, you're hearing the first step now. So I think the director is very receptive to healthcare concerns of the citizens here, and the
I hope this
beneficiaries of
testimony
Medicaid.
will give you know, some insight into what it will take. I don't know what number they're going to come back with, but you've heard from a provider. You know, and the MAC committee, we're not, you know, this is a volunteer organization. We're all appointed by various members, you know, government, lieutenant governor, secretary of state, So 24 of us, I think, yeah, 24 of us. So we're all appointed and we don't get paid anything. We have no financial dog in the hunt other than we want to see children get care because all of us are parents of autistic individuals. So we know what proper care can yield, and our citizens deserve that from this state. And there's a lot of great things we can offer.
Certainly.
Mr. Chairman. Mr. Chairman. Mr. Chairman.
Just second, Senator Blackman. We're listening to one of the parents speak. Thank you.
Yeah. Right.
Sure. I think we. Sure. Well, the department has initiated a change and increase in rate. So let's see what they come back with. Senator Blackman, you have a question?
Yes, and thank you, Mr. Chairman. And I really could not hear the last speaker. I don't know what occurred, and that's why I didn't know anybody was speaking. But my question is, Do we know what is the total amount of dollars that are dedicated presently through Medicaid to autistic students? And then if we were to do the increased amount first to, if it's the commercial rate, and second, if it is to what they are asking, the $31, do we know what that would do to the budget?
No, ma'am, we haven't looked at that. This is the first presentation on this, but they did provide us a booklet, and I'll make sure you get a copy sent to your office. But the Mississippi Medicaid rate for the code 97153 is $8.14 a minute. The Blue Cross is $15 a minute, and the maximum allowable amount is $31.25 a minute.
Yes, sir. I saw that on the screen, and I was just curious as to what we are expending now, and then what it would cost if we were to expend at the commercial rate and then at the $31 rate that they're asking.
Yes, ma'am. That's information we'll have to get from the department.
I can say on one of the slides that the Medicaid report that they gave, it's on page 12, that they have their allocated for specific codes for 21 and 22 listed out. And so it lists those, like for the 91573, $718,135 for that one. And then $195,245, and then $20,000 for the other code for 2022. So that's what they've allocated. Those numbers are from Medicaid. So I think that's
what's been paid out so far.
correct. Yes, sir. That's what's been paid out so far. So that's, you could take those numbers, and honestly, I tried to figure out how they came up with that number. I'm not sure what math they're using. So I don't know the formula, how they got that number, because out of 142 people at 32 units a week, I wasn't sure. I couldn't make the math work. So but that's their report. That's the money allocated so far. So Ms. Blackman, I think you have that booklet. I'm going to visit you. It's going to be on page 12.
Okay, thank you.
Yes, ma'am.
Do any of the committee members have questions? Senator Wiggins?
Thank y'all. I want to thank y'all for your presentation and your service and your passion for being here and what you're doing, because it helps us. My general question is, I hear we have to make decisions here. And we want every child to be able to have it. But we have limited amount of funds. And I can tell you, so today we heard postpartum care, and to extend postpartum care, that's $7 million. You talk to hospitals and that's another 10 million or whatever it is. And we only have a certain amount of money at the end of the day. So, and everybody's important. My question is, so what's your response? How is this? I don't want to say how it's more important, but what's your response? Because if we raise the rates, which it sounds like that's going to happen, then to the budget that we have, that's another X millions of dollars, which that also means that, depending, we got to pay for police officers and we got to pay for things like that. So how do we, and when I talk to constituents, and literally today, somebody was messaging me and they talk about Medicaid dollars. And they're like, why should I have, these are tax dollars that we're talking about. These are people's taxes are going to cover the state insurance, i.e. Medicaid. What is the response to the people that say, well, my tax dollars are going to there and, you have to be smart about the decisions that you make. What's your response?
Well,
how do y'all address that?
My response would be, number one, you have professional retention. You're keeping professionals that our schools, our institutes of higher learning are training. Ole Miss, University of Southern, Mississippi State, some of the community colleges have RBT technician school systems. So those you're retaining professionals, which keeps tax dollars in the state. They're tax-paying citizens. So that's keeping taxpayers here rather than training them and sending them away to make money somewhere else and pay taxes somewhere else. Secondly, you have a group of children or a generation of children who you can give adequate therapy to become taxpayers. That's what I say to that.
I like it.
It's all about money. It's all about money.
It is. And so when I get that, because I got it today, when I get that, I'm going to send you to them. No, I'm just
Absolutely.
Because, and I do think that's what we have to look at, is it's about the future.
Absolutely.
And where we are. But so many times from what I hear, people want to say, well, those are my tax dollars, and I don't think Medicaid program is, people need to be working for it and stuff like that. So I think we need to have these discussions so that people can understand what the decisions have to be made. Because if we're going to raise the rates, which sounds like we should, then, the budget cycle is every year. And so that means if we raise somewhere, somebody's going to lose something generally, unless the revenue keeps coming. So.
Well, we had that benefit of listening in on the obesity tested, whatever. And one thing I can say about that in comparison to what we're talking about is you have a group of people who there is an active role that they have to decide in their care. They get put on, whatever is offered to them, medications or lifestyle change, but they have to embrace the lifestyle change. That is a decision. It's a choice. Whereas
I hear that too about covering obesity under Medicaid. I didn't bring that up, but I hear that too, is like, that's their choice, but the presenters said it's not, or basically.
That's not true. I mean, you can control what goes in your mouth. Autistic children do not have.
She said, no, it's medication and there's all a bunch of factors, but that's what I'm talking about.
Sure, right. But there is choice involved, whereas these children, they don't know benefits if they don't have the benefits, if they don't have the therapy. And I can tell you unequivocally, personally, my son wanted to be better. He wanted to be independent. He wanted, in fact, he says all the time, why didn't God make me normal? Well, he's not broken. He's not damaged. He's different, but so we all are, but he loves having a job. He loves being productive. He loves having a purpose. And I could guarantee their children would probably say the same thing. And like Miss Wynn's son, he's a sweet little kid, and right now he can't control his emotions and he gets labeled as bad and gets in trouble, loses friends because his behavior. These children don't have a choice. That's how they're wired. And without adequate therapy, they won't learn tools to use their strengths to overcome their weaknesses.
Thank you very much.
Yes.
And I have one question before I let Senator Polk ask a question. Does therapy ever end?
No, you don't outgrow an autistic. Like I said, an autistic child becomes an autistic adult. Now therapy changes. Now Buckley is not in ABA therapy or intrinsic motivational therapy. What the therapy he receives once a week, he seeks out, and it's mainly counseling or life skills. Basically, and that's once a week, and sometimes
But for a lot
more
of
if there's a crisis.
A lot of these children, it's going to continue even into adulthood.
Absolutely, and it should.
Even if it's a visit once a week, just
That's correct. Well, because the brain isn't formed until you're 25 anyway. So, and these are emotionally younger, usually. Right. Yes, right. It's more like a counselor than there's no therapy. Yeah.
Right. Senator Polk?
Thank you, Mr. Chairman. I know we're running late, so I'm going to ask a question that I think is pretty much a yes or no answer, I hope. Thank you for being here, Ms. Spikes. And then with your research, you probably can answer this. Does any other state treat autism through another agency besides Medicaid? I.e., the more you sit here and listen, autism is not a physical problem.
No.
So does any other state have it covered and tend to it through rehabilitative services or mental health or some other agency, or does everybody treat it through Medicaid?
Well, I know private insurance covers the same thing, but I think it's all Medicaid. I mean, they're, yeah, it's a medical. Yeah.
Okay.
Right. But it doesn't encompass, yeah.
And I just got one more. I'm just curious. So your son's 25?
20.
20, all right. At some point, you and your husband aren't going to be around.
Yes.
What happens, or are there systems in place for these children who will be adults to watch over them or give them guidance, or do they need to be in a special home, or what happens after mom and dad pass on?
They have siblings. They have other family members. I mean, honestly, unless some that may need a kind of halfway house situation, and I don't know of any of those in Mississippi. I'm not familiar with them. We'd have to put his name on there now.
Is that also due to reimbursement, that there's so few? Yeah. Sure. Well, I share some of your concerns. I've got twin nephews who had Fragile X. They're in their mid-20s now. My sister basically has dedicated her life to take care of them. One is, I'd say, mildly impaired. He can function, he can work, he can go to school, but he still needs supervision. The other one probably should have been in a home from day one. And certainly from our family, it's what's going to happen to him when she can no longer take care of him. But and they're about the size that I am, and my sister's a little lady. But anyway, ladies, thank you for your presentation. Thank you for your passion, and we'll certainly see what we can do on our end to help. And to the committee members, thank you. Appreciate you attending. I got to give a shout out to my new committee assistant, Becky Mercer, for helping us put all this together. And then my policy advisor, Brittany Davis, for providing me with background information. So I can sit up here and ask some questions. Anyway, we are adjourned. Thanks.